down and get some.
I'd rather you put it in a
Right.
schedule.
Okay, now, yeah, you see, and
Well, I could have home playing all the time.
so,
This way I'm not feeling guilty, you don't have to do that.
we want to do two. Okay, then you want to try to go to me.
I'm vicious.
Okay, and welcome back from lunch. We are going to continue here, and we are streaming live now. We just verified, just wanted to make sure about that. And I will want to ask for clinical questions.
This meeting is being recorded.
And just in case you weren't sure, now you know for certain that we're being recorded. All right. So we'll basically just continue where we left off for lunch, and I will let Dr. Delaney take clinical questions on intracranial hypotension now. If anyone has questions, please come up to the microphone.
Hi, I'm Ting Langley. Currently,
documentation-wise, we have never seen the intracranial hypotension. But what we see is the spinal headache after epidural. For the delivery woman, they have epidural.
Yes.
Or a spinal surgery. So at what point would provider call intracranial hypertension that clinically, so that we at Coder maybe should start educate provider on this new terminology?
Not sure I'm understanding your question.
So at what clinical that we see in the records that consider this is an intracranial hypotension? Because we never see this document in a chart at all. And I think all coders here can attest to what I'm saying. We always see just spinal headache and treat with a blood patch, and that's it.
And that speaks to the fact that it's a very underdiagnosed condition. At least the spontaneous variety is underdiagnosed. And we're suggesting that needs to change. I think when Dr. Berglund goes through the rationale for the coding changes, he'll explain that it may be helpful to explain, to code not only the cerebrospinal fluid leak at the spinal level, whether that be spontaneous or iatrogenic or traumatic, and also code the intracranial hypotension, which is not just a headache, but many other neurologic signs, symptoms, and complications.
Well, we at our hospital, like many hospitals, do have a program that educate provider to document appropriately for certain conditions from a terminology. But in order for us to do that, we just really have to I don't want to say educate provider, but I want to say that if this correct diagnosis now going forward, should we place a query for you, or should you start documenting this kind of diagnosis? Because I can send this particular new diagnosis to the chief and say, what do you think of this diagnosis coming out? That can be easy done, but I just don't know the clinical involved in this new diagnosis to talk to providers.
Right. I think that's more of a coding question than a clinical question. I'm not sure.
It can be both, but you know, it will be under-reporting from us if we don't see the documentation from provider.
Mm-hmm.
Okay. And thank you. That's certainly I think a helpful comment, and it's the kind of thing that can be of interest. And if the healthcare provider doesn't document intracranial hypotension, then we wouldn't be using these codes, presumably, although if there are other things going on, then, well, if CSF leak is recorded or other things, then there would be certain codes that might be getting used. But if intracranial hypotension wasn't getting documented, then you wouldn't be coding that, presumably.
Coding or our CDI program can able to put this thought in their head that start documenting this. So that's the reason why we have to understand the whole diagnosis. That's why I'm asking at a clinical way, because we can put this wording in their thought, in their head.
Yeah. So there would be things we could do in dealing with that issue then also. Okay. Any other questions or comments? Not seeing any here. Let me ask the operator. Operator, could we please get the phone lines opened for comments?
All lines are unmuted.
Thank you. Any comments on the phone lines? Looking for clinical comments on the topic of intracranial hypotension. Our questions. And hearing none at this time, we will move on to the coding part of this proposal. And operator, please close the phone lines for now. And we will move on to the coding questions. We have these here, so we'll look next at how the codes would look here, and we'll look at G96, other disorders of central nervous system. At G96.0, we have cerebrospinal fluid leak. It's being proposed that we expand this that we add a code also note, code also spontaneous intracranial hypotension if applicable, and add new codes, G96.00 for cerebrospinal fluid leak unspecified, 0.01 for CSF leak from skull base spontaneous, 0.02 for spinal CSF leak spontaneous, and 0.09 for other cerebrospinal fluid leak. Next, at G96.1, disorders of meninges not elsewhere classified, we have the code G96.11, dural tear. We would add a note there, code also spontaneous intracranial hypotension if applicable. And then looking at G96.8, other specified disorders of central nervous system, we would be creating a new code here for intracranial hypotension, spontaneous with or without confirmed cerebrospinal fluid leak. This would be G96.81. We would have a code also note here for any associated diagnoses, such as, and we have quite a list of diagnoses here, brachial myotrophy, cranial nerve disorders and diseases classified elsewhere, nerve roots and compressions and diseases classified elsewhere, and a number of others that I won't read through, but these are of interest certainly, so look at those closely and comment if you like. We would also add a new code, G96.89, for other specified disorders of central nervous system, again, including our other disorders there. Next, looking at G97, the intraoperative and post-procedural complications and disorders of the nervous system not elsewhere classified. G97.0 is for CSF leak from spinal puncture. We would add notes here. We would add code also any associated diagnoses or complications, such as intracranial hypotension following a procedure. And at G97.1, other reaction to spinal and lumbar puncture, we would add a note there, an inclusion for other reaction to spinal dural puncture. The code G97.2, we would propose to modify the title. It's intracranial hypotension following ventricular shunting. Now we would make that ventricular or lumbar cerebrospinal fluid shunting. And also add a note to code also any associated diagnoses or complications. Next, G97.4 is accidental puncture and laceration of a nervous system, organ, or structure during a procedure. At G97.41, accidental puncture or laceration of dura during a procedure, which includes incidental or inadvertent durotomy. We would add a note to code also any associated diagnoses or complications. And at G97.8, other intraoperative and post-procedural complications and disorders of the nervous system, we would be creating a new code here, G97.83, for intracranial hypotension following a procedure. And we would add notes to code also, if applicable, accidental puncture or laceration of dura during a procedure, and cerebrospinal fluid leak from spinal puncture. And finally, we would propose at G44.8, which is going backward from the G97s, I recognize, but we included this at the end. For other specified headache syndromes, we would propose a new code, G44.86, for headache with orthostatic or positional component not elsewhere classified. So these are the new codes that are being proposed. One of the issues that we were just discussing during lunch, which you may be interested in commenting on, was how would you code intracranial hypotension NOS? And should this be an inclusion or potentially a separate code? Should this be included at G96.81? Or should we have a separate code for intracranial hypotension NOS to separate it from the spontaneous intracranial hypotension where you know that it's spontaneous. And we're open to input on that and whether we should really create a separate code for it or whether we should have the NOS go to that code. Other types, of course, do include the cerebrospinal fluid intracranial hypotension following a procedure or traumatic intracranial hypotension. So those would be ones we would be interested in differentiating. We're not proposing to do anything to create a code for coding intracranial hypotension that's traumatic. There are other trauma codes that would be applied, of course, but we're not proposing to do something else with that at this time anyway. So we'd welcome comments about the proposed new codes and about how to deal with any other not otherwise specified or other terms that we might encounter.
Okay, as a data analyst, I don't know how I would use these data because, okay, so we're coding anesthesia, and the day after anesthesia, they go and they do the post thing there, and they'll take care of any of the headaches, right? And so, depending on the documentation, if we go and we teach them how to document. Because right now, we just see blood patch because of headache, right? That's the only thing we see. Right, and so the thing is, should we teach them to document that it's a cerebral spinal fluid leak from a spinal puncture, or for all those epidural headaches, and then do I... So I'm just saying that I see this G97.1, which is headache due to other spinal dural procedure. I see the cerebral spinal fluid leak, and then I see a code for intracranial hypotension. And I'm going, I don't know how as an analyst I would figure out what was supposed to have been coded in the first place. It just depended on the documentation, but it's like documenting, you know, my name is Jean or my name is Yoder, and which one does it go to? And then I'm just, and which is why everything is so confusing to me. So I'm not sure as an analyst I could figure out what was intended based on this. Sorry.
Okay. Thank you.
Darlene Hyman. I'm just wondering if it's really necessary to have all these codes, or if we could just have one code for intracranial hypertension, and then a traumatic if you see a need for that, because you're already picking up the reason for the
CSF
intracranial
leaks or other things like that.
Following procedure, following CSF leak, because you're picking that up already. It just seems like a lot of codes. But.
That could have a clinical aspect to it. Would you like to address that aspect? Let me pass that to you.
A CSF leak can be, a spinal CSF leak can be asymptomatic, or someone could end up dying from it. And the range of symptoms and complications is quite large. So coding something as just a CSF leak doesn't tell you what's happening to the brain and spinal cord, whereas intracranial hypotension encompasses that. So we're saying that there should be a code for the leak, and there should be a code for intracranial hypotension, and intracranial hypotension should be coded separately if it's spontaneous versus if it occurs as a result of a medical procedure. That's what we're suggesting.
Okay, thank you. Yes.
Teresa Hannick, IMO. Just some suggestions perhaps to think about for streamlining this proposal. If we keep the intracranial hypotension at G9681, I would suggest just intracranial hypotension with inclusion notes for spontaneous and traumatic, and then add the code also associated diagnosis to pick up the trauma there. So you can use G9681 for spontaneous or traumatic, either one, and then the other codes would help tell the story about why this patient is experiencing hypotension. I do not agree with the includes, or the code-associated diagnosis for the symptom at R41. You wouldn't code that. I don't think. I would think the symptom would be a part of the syndrome and not separately coded. At G97-2, no, not that one. I was wondering if at G97-2 is intracranial hypertension following the shunt, and then you proposed a new code at G97-83 for intracranial hypertension following procedure. My question is, can G97-2 become a subcategory with 2 codes under it for G97-21 for the shunt, and then G97-89 for intracranial hypertension following other procedures, so that they live together and not in separate subcategories?
It's an interesting question. We do have the existing code there that I think came from WHO that was specific for the ventricular shunting. And I think if it was just described as intracranial hypotension following a procedure, I think that you would end up at the G97.8 right now because of that difference. So the intention here was to try to keep these as close as possible to what WHO has within the base ICD-10 that the clinical modification is based on, but yet to give this additional detail for these kinds of cases. So.
Yeah, I understand that. I just
Yeah,
wondered if we
yeah.
could push them together, because two types of intracranial hypertension, both from procedures, I think should probably live together. And then the other question I had is in G4486, the headache with orthostatic or positional component, is that truly a syndrome or is that a symptom?
So the G44.8 is other specified headache syndromes, and you're wondering if this would be a syndromic headache, or should it more properly be considered a symptom of something else and then maybe be instead sent to the signs and symptoms,
Yeah, a subcode
the
at
R code
R51.
somewhere? That's a question to think further about. We do have certain other headaches in other places related to this. Would you want to address that any? Would you say that a headache with a positional component that isn't classified elsewhere, is it really properly a headache syndrome as opposed to a sign or a symptom of something else then? I'll let you.
I think the experts were suggesting it because the patients that are being evaluated for intracranial hypotension, sometimes it's not obvious if it's spontaneous or iatrogenic, because the imaging is sometimes negative. Patients may actually have a concurrent a comorbidity that makes it kind of complicated to sort out with the negative imaging. Is this intracranial hypotension for sure? Or is it, and so they fit the clinical pattern, or are we not sure yet if that's what they are? So this is intended as a way for clinicians to sort out this sort of gray zone of patients.
Right, which I understand, and I think I don't have a problem with the wording. I just think it belongs
Where it
in
belongs.
the symptom code,
Right.
symptom section, and not as a headache syndrome.
You might be correct,
Yes.
yeah, I don't know.
Thank you.
So that's something we'll evaluate further. Thank you for the comments on that. Yes.
So then go down to the actual sequencing principle diagnosed when we assign his case. I'm just going to strictly talk to G9783. You just skip it, right?
There we are.
G7983.
So
Yeah, 83.
9783.
Co also, if applicable. G9783. You just mentioned that what?
Can we go back
G97.
down next page, G9783, so page down once more. G9783, there it is, okay, let's just stop there.
Okay, so from perspective of coders, when we look at this, any complication for admission is going to be a principal diagnosis because of the complication of admission, right? So now you have two things going on. How will you advise us to sequence if the patient has intracranial hypotension? Can we assign, because the patient discharged from the hospital after a spinal surgery and came back and found out to be a dural laceration led to intracranial hypertension. So which sequence do you want us to go first? If you give us this information code also, we would pick whatever we like.
And at this point, it was left in a way that you would be able to choose potentially either one, depending on the circumstance of why they were there. Do you think we should be choosing a specific one of these? Should we be saying that this code has to go first, do you think? Do you think this code has to go second then? So the accidental puncture or laceration of dura during a procedure, the G97.41, this should always, the G97.41 should always come before this one then, you think? Or the other, okay. This was a note at G97.83, intracranial hypotension following a procedure. And there's a code also, if applicable, note for the accidental puncture or laceration of dura following a procedure, G97.41, and for CSF leak from spinal procedure, G97.0. All of these are codes that are at G97. Should we be specifying this as something else, and if so, what?
Well, if as a coders, if you will not tell us which one you would like to see go first at principal diagnosis, we will pick what we like at principal diagnosis, because it looks like to us coexisting, coming with both, because let's just say the scenario I just gave it that when a patient discharged home with spinal surgery, now just came back with headache and so on, the diagnosis intracranial hypertension. The cause of this is coming from laceration of dura. Laceration of dura is always well documented because I'm coming from a spinal hospital. So should we assign the accidental puncture laceration of dura as a principal diagnosis? Or should we assign the intracranial hypertension following? You tell us what you want us to see, what is considered important to you, and we will follow that rule. I'm just telling you that now. So what is your opinion? What would you like to see?
Okay. Did you want to comment on that?
It's more of a question that I have. I mean, when I think of a CSF, an iatrogenic dural defect, I think of the defect as being the surgical complication, and I think of the central nervous system result as being downstream from that. So I don't know, should intracranial, let me see if I can find it. Should intracranial hypotension following a procedure be under the G96 codes next to intracranial hypotension spontaneous? Because it's a specified disorder of central nervous system, you're just differentiating whether it's spontaneous or iatrogenic.
Well, I'm just talking deep down to actual how coding report this data out to you. And we have what is reason for admission, assign a principal diagnosis. I'm just strictly saying code also applicable. For us, we're probably going to use 69741 at first and followed by that. It's based on what you just tell code also applicable. We can pick whatever we want. So I'm just saying, but you also have instruction rules say code first if this relates to this. So if you want us to assign G97.41 at principal diagnosis, followed by G9783, we can do that. But I'm just speaking from a coding standpoint of coding rule code also, if applicable. Or do you want to change to code first if hypertension relate to accidental puncture of laceration during a procedures? So that's just strictly coding rules that I'm asking. So if you want us to code also, then we do have a choice of picking which one we want to be a principal diagnosis. That's what I'm saying.
Right, yes. At this point in time, we'd left that somewhat open. We're certainly willing to take thoughts on whether you think this should be a different kind of note, and we'll welcome input on that.
I would actually like to speak in favor of keeping it as you have it with the code also. I think that makes more sense and leaves some flexibility depending on the actual specific circumstances around the encounter and what the focus of treatment is and why they were admitted, what else is going on. And I prefer to have the code also and not be forced into a particular sequencing that may not make sense in a particular circumstance.
Okay, thank you.
Nellie Leon, she's saying AHA, and I agree wholeheartedly with what Sue said. I think this note, the way it is, code also gives flexibility so that, and I know sometimes coders can feel like you need to tell me, but when we've had code first, where it's just an unbreakable code first, then we hear about complaints about, well, this doesn't make sense, why did they do that? But code also provides the ability to actually identify what was the reason for the admission, what's the primary reason for the visit and all that other stuff. Let's leave it as code also. Thank you.
Okay, thank you. Okay, Linda.
So I have several questions.
You have to have the computer to help remind you what they all are, I can see.
Yeah. No, it's I think modest. I didn't quite follow about the CSF leak from the nose or the ear. I do understand that happens, and I do see that documented. But it's not clear to me where you want that coded, or whether you consider that significant, or whether that's even a component of this proposal.
We did not address that, and that could be any of a few different things that were causing a CSF leak. So leaking from the nose or the ear, that would, if it was spontaneous, that could be at the G96.01. The new proposed code that's there, or if it was following something else, following the procedure, it could be at G97, or if it was traumatic, it could be somewhere else that we don't even mention here. Dr. Lin, would you want to comment on any of that?
I got the impression that, which I think is wrong, that you didn't consider that to be significant.
Oh, if
it was coming from the nose or the ear.
If it's actually coming from the nose or
And
the ear.
I know that can't be correct, so what was it you were intending to say?
We didn't address that in this, but Dr. Lillian, what would you say about that as a clinical issue?
Certainly. From the clinical perspective, we were just pointing out that CSF leaks that occur at the skull base, which are ear or nose usually, don't have anything really in common with CSF leaks that occur at the spinal level in terms of underlying causes and whatnot. So having one code for CSF leak, undifferentiated, is problematic.
I understand you. So where we have the proposed code G9601, can scroll.
Right.
Thank you for clarifying that point, Doctor.
G96.01. So shall we scroll up one more? Actually, one more beyond that. There we are. Okay. So the new code G96.01, cerebrospinal fluid leak from skull base.
So maybe
this is the kind of thing that would result in potentially spinal fluid coming out of the ear or the nose.
Right. So that's one of the ways that we can.
If it's spontaneous. On the other hand, as we'd said, there can be other things that can cause that also, such as certain types of trauma.
I do understand that the intention here is to differentiate between CSF leaks from the brain and CSF leaks from the spine,
Skull base,
which makes sense. My concern is that by saying from the skull base, I'm not going to see that terminology in the medical record. And not being a physician, I'm not going to know that that means nose and ear.
I wonder if you should add the commentary that you often have, and I think the current code for cerebrospinal fluid leak has comments about CSF rhinorrhea. I don't know if it includes autourea as well, but that could be added as comments.
This is
so
where
that-
I'm going with this as a
Right, yeah.
coder, is to say that we made it an inclusion term under G96.01 to say that when we say CSF leak from skull base, we could include something like, otorrhea, rhinorrhea, CSF from nose, ear. I mean, obviously, it's not coming from the spine if it's coming out of your nose or your ear. But my concern is that people will just say, oh, G9600, 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 and then you won't get the data it is that you're looking for. So if from skull base means you'll see it from the nose and you'll see it from the ear, let's say so. Moving on. I didn't quite understand until just now that the distinctions that you're making here are spontaneous, iatrogenic, and traumatic, that those are the three basic causal factors here. So when I saw the word spontaneous, I thought, well, are we going to need to see the word spontaneous in the record, or is that just there to remind me that it's not traumatic or whatever? So I guess my thought here from a coding perspective is that maybe we put the word spontaneous as a non-essential modifier first, and second, somewhere on these notes, maybe an excludes note or an instructional note or something, to make clear that if it's iatrogenic, go here, and there is the excludes note for the G970, and if it's traumatic, go somewhere else. So the next part of my question is, how common is the traumatic CSF leak, and do we need a specific code for that? I mean, if it happens, 6 times a year, we don't need a code. But if it's common enough, maybe we do.
I'll pass that to you.
We thought about asking for a code for traumatic, but when we looked at the trauma codes, we got dizzy.
I look at them more than you do, and I'm more dizzy than you.
One of the issues when you're doing imaging for spinal imaging to look for a leak, sometimes you see contrast literally from top to bottom of the spine and you don't know where the origin is. And when you're looking at trauma codes, they're broken down into neck, thoracic, lumbar, and sometimes you don't know. So we just really didn't know how to code that. We were somewhat less concerned about having a intracranial hypotension, traumatic code because it is less common than the other two. I mean, obviously the iatrogenic seem to be the most common. Spontaneous is not uncommon, but traumatic doesn't seem to be as common. So we weren't as concerned about identifying that. But then that comes back into the question of the not otherwise specified, intracranial hypotension, not otherwise specified. Could it fall under there? Maybe. I don't know.
Or not elsewhere classified. Yeah. So if we're trying to make the distinction here between iatrogenic, spontaneous, and traumatic, we're going to have to do something with traumatic. So it may be a new code, or it may be putting an inclusion note somewhere else, or an exclusion note, don't code traumatic here. We're going to have to do something with it.
Well, that's definitely something we'll have to look at further, too.
Okay.
So I appreciate all the inputs and thoughts. Let's see. Linda, you're still looking at your list on your computer. Let's try to wrap up relatively quickly.
Just one more point.
One more question.
Yeah,
Okay.
no, it's not even a question, it's just a point. I agree with Darlene that it seems like there's just too many codes. And you said that you get dizzy when you look at all the trauma codes. I know one of the purposes of ICD-10 is to have much greater granularity, but you can also get paralyzed by too many choices. And I think if we have like one code for intracranial hypotension, and then we can use additional codes to show how it came about or whatever, that might take care of some of that paralysis. And now I'm going to sit down to make you feel better.
Okay. And given the timing, I think we're going to need to move on. So at this point, I'm not going to ask for further questions on the phone line. Sorry. Anyone on the phone line who has more comments and questions, please do put those in writing and get them to us. We appreciate that. Dr. Darlene, thank you so much for being here and for presenting this. And we're going to move next to the next topic, which will be Prader-Willi syndrome. And we have a person here to present this, Dr. Dan Driscoll. He will be coming forward. And Dr. Driscoll, I'll welcome you to come forward. We will try to move to that presentation shortly. That should be appearing here shortly. Those following along, this will be on page 42 of your handouts. And we will move smartly along to this. Dr. Driscoll, thank you for being here. You are well known in research in Prader-Willi syndrome. I will let you introduce yourself a little more and tell us more about yourself. I'm sorry not to give you a more detailed introduction, and thank you for being here so much.
Well, thank you. And thank you for having me, and particularly Dr. Berglund, who's been working with us. As he said, I'm Dan Driscoll, and I'm from sunny Florida. And just a brief description of affiliations, disclosures. I'm a professor of pediatrics and medical genetics at the University of Florida College of Medicine. I'm also chair of the National Clinical Advisory Board for the Patient Advocacy Group, and also chair of the International Clinical and Scientific Advisory Board. And I was also the principal investigator on the NIH-funded Rare Disease Clinical Research Network natural history study of Prader-Willi syndrome, which was funded for 11 years. Funding's run out, but we're still analyzing the data. And I did my training just down the road at Johns Hopkins, so I'm very familiar with Baltimore and has a special place in my heart. And my mentors. And this request to the ICD-10 committee is on behalf of the patient advocacy groups, the Foundation for Prader-Willi Research, Prader-Willi Syndrome Association USA, and IPSO, the International Association. And I'll talk a little bit more about each group. The Foundation for Prader-Willi Research was founded in 2003 and is primarily research, raising money for research. It started in the U.S., it branched out to Canada, and now it has involvement from various parts of the world, Australia, New Zealand, Europe, funding research grants, and so far they've funded $10 million in research. The Prader-Willi Syndrome Association USA was founded in 1975, and has served greater than 8,000 families through the years. It's primarily a support organization and an advocacy group, but they also fund research. And as I go on, you'll learn more about the syndrome and the special needs, and that's why these families and their children need a lot of support. And then the International Prader-Willi Syndrome Organization, founded in 1991. We have international meetings every 3 years, and we have representation from 105 countries across the world and represents over 25,000 families. So Prader-Willi syndrome is a complex neurodevelopmental disorder. It's the most commonly diagnosed, however, genetic cause of obesity. Most causes of obesity are still complex and being elucidated, although we do know many single gene defects. But Prader-Willi is diagnosed more than any other known genetic condition for obesity. The prevalence is anywhere from 1 out of 15,000 to 1 out of 30,000, and it doesn't discriminate. Males, females, equally, all races, all ethnicities across the world. And DNA methylation analysis can diagnose greater than 99% of cases. It's a fairly straightforward test that was pioneered in my lab in Florida in the early 90s and now is used across the world, and can even be done from a blood spot mailed in from India to, we have a referral lab in Italy that'll do free testing through the international organization. And then I'll get into more detail, but initially the children are very hypotonic, floppy, and they don't have an appetite. So they're failure to thrive, and they need to be assisted feeded, typically with an NG tube. In about 25% of cases, we have to put a G tube, a gastric feeding tube in, and for several months until the appetite kicks in and the tone kicks in. But the key thing we've learned is that they're not interested in eating. They will not cry and wake the parents up in the middle of the night, which some parents may think that's a good thing, but it's actually a bad thing because they'll starve to death because they're just not interested. Hypogonadism, hypotonia, lack of muscle tone. And then later on, and I'll go into more detail on this, the appetite improves, and then it improves some more, and then it becomes insatiable. And here's a 2.5-year-old, which is a little bit early to get this obese, but you can see she has an old G-tube site there, skin picking sites, where they're compulsive skin pickers, most of them, and then an adolescent. So the major features, just to go over in a little bit more detail, is the obesity and hyperphagia, the increased appetite. But what makes this unique in genetic obesity syndromes is initially they're hypotonic and fail to thrive as neonates. They don't have an appetite. There's hypogonadism with typically infertility. We've only know 4 women in the world that have reproduced and no males that have reproduced. Characteristically and traditionally, there was short stature, small hands, and small feet. But in the late 80s and 90s, we discovered they have a growth hormone deficiency. And in 2001, the FDA approved growth hormone treatment with the indication Prader-Willi syndrome. And this will normalize the stature. Characteristic behavior, including obsessive compulsive behavior, very perseverative, mild to moderate intellectual disability. And the very intriguing thing about this condition, it's a lack of a paternal contribution on chromosome, the proximal region of the long arm of chromosome 15, the coordinates 15q11 to q13. And I'll talk a little bit more about that. But this is an example of genomic imprinting and epigenetics. And genomic imprinting affects only a small percentage of our genes, probably less than 1%. Most of our genes are Mendelian. It doesn't matter if the mutation comes from your mom or your dad. It's going to be equally deleterious. But in the imprinted conditions, there's certain regions in our genome that are only expressed coming from a dad and certain regions only expressed coming from a mom. So if you ever wondered why you needed both a mom and a dad, it's because of imprinting. I can take a frog's egg or a chicken's egg, and I can stimulate that egg to go into a chicken, a turkey, a frog, without a male contribution. But in mammals, you can't do that because of this imprinting. And epigenetics means regulation above the level of the DNA. There's secondary regulation. And so there's a number of medical practitioners that are involved in Prader-Willi syndrome, and they're on my clinical advisory board. And we had meetings and phone conversations about this subject, the ICD-10 code, which is Q87.1 for Prader-Willi and many other conditions. So the input I've gotten and I'm representing today is not just as a medical geneticist, but all these other specialties that are involved in the care of persons with Prader-Willi. So endocrinologists, development, nutrition, pulmonary, orthopedics, psychiatry, psychology, GI, ophthalmology, dentistry, and of course, primary care practitioners. I always have to make sure I say that because my wife's a pediatrician, and she reminds me the specialists feed into the hub of the wheel. We're just the spokes. And so I'm just going to go over a little bit of the genetics, not so much to make you all geneticists today, but to give you a sense, a little bit of the complexity. So the blue represents a paternal, a father contribution, and the pink maternal from your mother. So we each have a contribution from mom and dad. We have 46 chromosomes, 23 from mom, 23 from dad, 2 of each type. And so this region in here is a very important region. And you can get Prader-Willi syndrome by deleting that region, uniparental disomy, or an imprinting defect. So deleting it, you delete 5 to 6 million base pairs, the region's gone. And so there's no paternal contribution, and that's about 70%. And then the maternal uniparental disomy, mother, one parent, but 2 copies. You have 2 normal 15s. You look under the microscope, there's 2 normal chromosome 15s. Under the microscope, you can't tell the difference between a mom and a dad chromosome. But again, the key thing is you're missing the paternal contribution. And then an imprinting defect, the region is from the dad, still thinks it's from the mother. So basically what happens is the dad's mother passed her 15 on. In spermatogenesis, the father is supposed to wipe the memory of his mother and put a male imprint on. But sometimes on the assembly line making sperm, it doesn't always happen, and the paternal grandmother's imprint comes through. But basically, it's a defect in the imprinting process. But the key thing is you're missing a paternal contribution. And this is just to give you a sense of the complexity. There's over 20 genes in this region. The ones in blue are only expressed coming from a father. The ones in orange are only expressed coming from a mother. And the greens, they don't care. They're biparental. And one of the genes for albinism, cutaneous albinism type 2, is right here. And there's various size deletions, et cetera. And in the fall, the Angelman group presented. And the Angelman syndrome, much different syndrome, is also a defect in this region, but it comes across on the maternal chromosome. So if you delete or uniparental disomy UB3A, or if you have a mutation or an imprinting defect, you get Angelman syndrome. Very different, but it's the same exact chromosome region. And if you look under the microscope, you see a little deletion, but you can't tell if that's on the mom or dad's chromosome. The syndromes are very different. So my group led an effort over the last 10 years to really look at the nutritional phases, what's going on in Prader-Willi syndrome. And we've described 7 phases and subphases. The first phase happens prenatally. During the pregnancy, there's decreased fetal movements, and when the babies are born, we looked at 100 Prader-Willis and 100 SIBs. They're about 15% lighter than their siblings. The birth weight typically is in the normal range, but if you compare them to siblings, it's 15% less. The first phase, 1A, is poor feeding. They have a lack of appetite, and they'll fail to thrive, and they'll die if you don't assist feed them. And that lasts for about 9 months. Then about 9 months, plus or minus, the babies start to feed better and start to get on the growth curve and have a pretty good growth and normal feeding. And then at about close to 18 months, 24 months of age, the weight starts going up without an increase in calories or an increase in appetite. We have to drop these babies to 60 to 80% of the recommended daily allowance, or they'll become obese. We've known for about 30 or 40 years that the weight went up at 18 to 36 months, but what our group showed was it's going up without an increase in calories or appetite. The increase in appetite happens later, and the median age was about 4.5. They start to have an increased appetite, increased interest in food, start talking about it. By 8 years of age, they're always hungry, and they have a lack of satiety. They don't feel full. And we call that phase 3. And then phase 4, some of the adults, I have 70 adults that are cared for in town in Gainesville in group homes. And some of them start to lose that insatiable appetite in their 30s and 40s, not all of them. But it's a wonderful model to understand appetite regulation and weight gain, et cetera. And I think will elucidate a lot with this syndrome. So there's another term out there, Prader-Willi-like. And it means to say they don't have Prader-Willi syndrome, but they have a lot of features of Prader-Willi syndrome. And like not just the obesity and increased appetite, but maybe the perseverative behavior, maybe the skin picking, maybe the failure to thrive as a newborn, but that's very rare. But it's just kind of a little bit of amorphous, heterogeneous term to say, you know, this kid's got a lot of Prader-Willi-like features. And particularly the psychiatrists and psychologists like to be able to have a term to use because they want to get services for their patients. And sometimes we have a syndrome like Schaaf-Yang or Temple or SIM1 or a deletion on chromosome 16, and sometimes what's called an acquired Prader-Willi syndrome where there's a damage to the hypothalamus and then they become very Prader-Willi-like. But most of the time we don't have a syndrome, a name, a genetic test that proves that a particular condition. But these patients still need services. So those 70 individuals that live in Gainesville, adults that live in group homes, the person with the most insatiable appetite that elopes, in other words, leaves without permission, the group home the most frequently actually isn't one of my Prader-Willi patients, it's one of my Prader-Willi-like. And so a number of people on my boards feel it's important to have a separate code for them. You don't want the same code as Prader-Willi because the genetic testing is going to be different, but a code. And I'm reminded of a family years ago that I saw in clinic, and the mother said to me, you know, in medical genetics clinics, we don't always have answers, and sometimes we don't know what's going on, but the kid's got a lot of problems. And so one of these families, the mother said to me, Dr. Driscoll, I'd rather have the wrong diagnosis than no diagnosis. Now, I told my colleague Charlie Williams this, and he didn't get it. But I get it because you get a lot more services when you have a code, right? I mean, you have a name, and people ask, why is your kid so heavy? Why is your kid overweight? Well, if you say Prader-Willi syndrome, it's dramatically different. And we'll get into a little bit about growth hormone, but you get a lot of services if you can prove Prader-Willi syndrome. So the current ICD-10 diagnosis, congenital malformations, and under that is congenital malformations predominantly with short stature. And you can see that Prader-Willi syndrome is lumped in with a bunch of other syndromes. And this is just the tip of the iceberg. I was showing Dr. Berglund before lunch 4 pages from EPIC, our electronic medical record. Unlike Vanderbilt, we've had it for 10 years, and it's very demanding. But at any rate, there's 4 pages of different syndromes and conditions that have Q87.1, and Prader-Willi's lumped in there. So we feel we need our own separate code. In ICD-9, we had our own separate code, and then in 10, we lost it. These are 2 brothers. So remember, it's coded now, congenital malformations with short stature. Well, these are 2 brothers less than a year apart. This is the brother with Prader-Willi syndrome, and this is his normal sibling who's a normal height. And actually, he's greater than the 50th percentile for height. So he's on growth hormone. We've been using growth hormone since 2001, FDA approved. It normalizes the growth, and if you give too much, you can make the kid too tall and almost Marfanoid-like. It improves, the main reason we want it though is it improves body composition, gives them more muscle mass, more metabolism, and actually they can have more calories. My adults that I was talking about in Gainesville, they're on 1,200 to 1,400 calories a day. And some a little bit more, some a little less, but if I put some of these on a typical American diet, they'll all be obese with a BMI greater than 50. Many of these patients come into the group home 300, 400 pounds, and we gradually reduce that weight 1 to 2 pounds per week. And it also improves particularly motor development. Some people think cognitive development, but growth hormone's not cheap. It's $30,000 to $40,000 a year for the children. Now the adults, if we put them on it, we put them on a lower dose, and it's maybe only $10,000 a year. And the insurance companies since 2001, Barbara Lippe got the FDA approval for growth hormone for us. But if we put down Prader-Willi syndrome and we have a genetic test to prove it, the insurance companies will pay for growth hormone replacement, $30,000 to $40,000 a year times the length of the childhood, and then adulthood dropping to $10,000 a year. So why do we need a unique code for Prader-Willi syndrome? The other ones that I showed you on that list, and there's many more that aren't on the list that are Q87.1, have very different mechanisms, they're different genetic causes, different clinical phenotype, different incidence rate, inheritance, different treatments, and as I said, short stature is not an issue anymore in Prader-Willi syndrome because every child with Prader-Willi syndrome should be on growth hormone beginning shortly after diagnosis, which is typically in the first 1 to 2 weeks of age, shortly after birth. We're picked up on it because they're hypotonic, floppy, and have hypogonadism and don't have an interest in eating. So the geneticists get called in and make the diagnosis and do the DNA methylation analysis. So what are the benefits of having a unique code? I think you all can figure that out, but it's improved communication for medical management, for research purposes, to find out the complications and the prevalence, develop standard of cares, facilitate clinical trials, ability to track clinical interventions, and improve access to various resources, and also to help the billing agencies, the insurance companies, because if I'm in a satellite clinic and I write Q87.1 and I'm ordering a DNA methylation test, there's all these other syndromes there, and a DNA methylation analysis is inappropriate for all of them except for Prader-Willi syndrome. So I think that's an important issue. And Dr. Berglund has been working with us, and he's made, I hope I'm not stealing too much of his thunder, but he's made some proposed coding changes, giving Prader-Willi a unique code, and then Prader-Willi-like, and then lumping all these other ones, which probably need their own code sometime too, but associated with short stature under another code. And that's a huge improvement for us being singled out and having our own code. We would suggest or would like some tweaks to that, in that a code that also specifies Prader-Willi syndrome confirmed by genetic testing. The reason for that is that a lot of our individuals out there are 30, 40, 50 years of age and haven't had appropriate genetic testing. So the syndrome was described in 1956 by Prader, Labhart, and Willi, but it wasn't, we didn't have a genetic test till 1981, and that only picked up 50% of cases. And that was like high-resolution chromosomes. Then, in the early 90s, the DNA methylation now picks up virtually 100%. But a lot of our adults haven't had the testing, or there's physicians out there, non-geneticists, that have somehow labeled someone that has obesity and hyperphagia as Prader-Willi syndrome that doesn't. So there's clinical diagnosis, but then there's proven by a genetic test. Now, I had a conversation with David Flannery, the medical director at the American College of Medical Genetics, and he and I both agree that it's always going to be a genetic test that diagnoses Prader-Willi. The test may change, although the DNA methylation is very robust and very easy to do, but it will always be a genetic test. We cannot envision another non-genetic test diagnosing Prader-Willi, so it'd be nice to have that. Also, the insurance companies will not pay unless you've had the genetic testing done that proves Prader-Willi syndrome. And then the second little tweak we'd like is that, going back to Prader-Willi-like, it's not a syndrome, it's a heterogeneous group. It could be a number of known syndromes like SIM1 deletion or 16p11.2 deletion or Schaaf-Yang. But most of the time, we don't have a genetic test that proves what it is, and we're just lumping these characteristics in. So I don't like the particular word calling it a syndrome. Prader-Willi-like, Prader-Willi-like condition, Prader-Willi-like phenotype. that would be preferable to us because syndrome implies you know what's going on and it's a specific entity, not a heterogeneous group. Much like I use the term morphinoid habitus. So there's patients with morpham, but there's others that have the same skeletal features but don't have the eye involvement or the aortic root dilatation. They don't have Marfan syndrome, but they have the morphinoid skeletal features, kind of like Abraham Lincoln or someone with Fragile X and Ehlers-Danlos, for instance. So I think that's the end of my little talk, and I don't know if we should entertain questions now or later, but I'll turn it over to Dr. Berglund, and thanks for your attention.
Sounds good. And any questions now? Clinical questions now for Dr. Driscoll. Any clinical questions, please come forward. Not seeing any here. Let's open the phone lines for clinical questions. Operator, could you please open the phone lines? Let's get the presentation up. Tracy, could you move to page 44? And we have that up now, and not hearing anything from the phone lines, we'll just move on. So we looked at this briefly. Again, the current structure at and okay, you can ignore the extra copy of the line that says new code for Prader-Willi syndrome at the top. I hadn't realized I did that twice, but anyway. Near the middle here we have a new code, Q87.11 for Prader-Willi syndrome. And again, this is at Q87.1, which is titled Congenital Malformation Syndromes Predominantly Associated with Short Stature. The current proposal is, again, the new code for Prader-Willi syndrome, and then a new code Q87.12 for Prader-Willi-like syndrome. Again, it was suggested that maybe we should title it something like Prader-Willi-like condition or Prader-Willi-like phenotype. And I will also comment that WHO has in ICD-10 a genetic syndromes with obesity as a feature. Something like that might be something else to consider. Of course, this one also involves some obsessive compulsive traits and the skin picking. So these would be other things to think about. And then we would also create another code, the .19 for other congenital malformation syndromes predominantly associated with short stature, and all the other things would go there. So that's where we're at. I'll open it up for questions or comments. Dr. Linzer.
Thank you. Jeff Linzer, American Academy of Pediatrics. First, as far as the coding sequence, if you were to have multiple, I would suggest not using just 5 digits because then you're going to run out of room too quickly. You would put that, for example, Q87 1, and then you'd have the 110, et cetera. The American Academy of Pediatrics supports and the re-implementation of a code for Prader-Willi syndrome that we had placed in I-9. I would like to remind the presenter that there are no diagnostic criteria in ICD, and that a physician is allowed to make a diagnosis based on the highest level of clinical certainty. So while there is a genetic test that you would use, technically the physician doesn't have to use it to make the diagnosis. We disagree with putting a unique diagnosis code in for Prader-Willi-like syndrome. We feel that's too generalized and would not appropriately be used, and that other symptom and complaint-based coding would suffice at this point in time.
Okay, thanks. Dr. Driscoll, would you like to comment on any of that? Or respond to you?
So I guess physicians are allowed to make diagnoses, but we would encourage them to make correct diagnoses. And there is a good genetic test that's used around the world, and we'd like to differentiate, from those that are using their clinical judgment, which may or may not have much experience behind it. But if there's a genetic test, we're trying to urge people to, if there's a genetic test that proves a diagnosis and you're labeling somebody for the rest of their life with that, you want to make sure you get it right. And there's been a couple of cases where the lab screwed up the testing for various reasons, and the child was treated like they had Prader-Willi syndrome and treated with growth hormone, and then found out with retesting that it wasn't Prader-Willi syndrome. So those physicians and institutions had a big lawsuit on their hands, and they ended up settling. So, you know, what I'm saying is, if there's a genetic test, we want them to use it. I think also having a code for that will encourage them to make sure that they've proven it. But, you know, as a medical geneticist, I'm very aware that to try to make the right diagnosis, because then families start to have expectations and there's medical management revolving around that diagnosis. So you want to get it right.
We don't disagree with that, and that's the place of medical societies and medicine in general in guiding physicians how to make the diagnosis. I'm just saying it's not the place of ICD to use that type of terminology in the diagnostic code set.
Well, I'm certainly not an ICD-10 or expert, but you know, I actually don't think it's too much to ask for, you know, 2 codes, Prader-Willi and then Prader-Willi proven by genetic testing. When I try to code my Prader-Willi patients or others to say, oh, they have type 2 diabetes or some other things, it's just like 30 choices for type 2 diabetes. So that's my comment on that. And then Prader-Willi-like, there are patients that need services, and without some sort of home or code, a lot of the people on my board feel that it'd be harder for these patients that have a lot of features like Prader-Willi, specifically the insatiable appetite and the perseverative behavior. They benefit from some of the same treatments and management, but if there's no diagnosis, it makes it a lot harder to get services. And the final thing I'll say is the insurance companies are not going to pay for $30,000 a year of growth hormone for 20 years unless it's proven by a genetic test. So, you know, we're encouraging people to do the right thing.
And as Ms. Pickett said at the beginning of the session, the issue is not reimbursement. The issue is resource utilization and quality improvement. So the Academy does not believe that a Prader-Willi-like syndrome or condition justifies a unique ICD code in the same way you wouldn't have something for diabetes-like syndrome or sickle cell-like syndrome. Patients can have very similar type of conditions without having the definitive diagnosis, and in the ICD code set there are other ways of coding those patients.
Well, I will say that you can find an ICD-10 code for Treacher-Collins-like and for Morphinoid habitus, or Morphinoid-like. So there's precedent.
Okay. Linda.
I'll make it quick. I agree completely with Dr. Linzer that I'm a coder, not a physician, and the chance of if I see in a chart that the physician has documented Prader-Willi syndrome, the chance of my going to that physician and saying, do you have genetic testing on that? The chance of my doing that is 0, and possibly less than 0. It's not the job of the coding system to enforce the standards of the specialty society on diagnosis codes. This is the wrong forum for that. Nobody disagrees that they should get a genetic test. Of course they should. But the coding system is not the vehicle for doing that. And then for Q87.12, Prader-Willi-like syndrome, I went back and forth on that. I don't quite feel as strongly as Dr. Linzer. My only point here would be that if you do retain that code, you put up a slide that listed some of those other types of conditions, it would be worth putting those, like I think it was Temple syndrome was one of them, and Schaaf-Yang, I don't even know how to pronounce it. It would be worth putting those as inclusion terms under Q87.12 if you wish to retain that.
Right. Now, you might have noticed when he showed the genes involved, one of the things he showed was a single gene disorder that was related to one of the genes that was there. There are certain other ones that, while comparing that, say, to Angelman syndrome that we talked about before that had the ability for the syndrome itself to be caused by a single gene mutation, the single gene mutations in this case would probably cause what we're sort of talking about as a Prader-Willi-like syndrome rather than the other. So there's things, it would be nice if we can figure out a way to do that. We're open to ideas. Given how much time we've already talked about it already, I'm going to ask everyone to please put your thoughts on this in writing and send them to us. If we come up with better ideas, we may end up bringing this back. That's certainly not impossible. And I'm not going to promise anything on what we'll end up with. And given the snow we've had, you might not really want to come back up here from Florida, and we otherwise would find some ways to deal with that, but I do appreciate your being here very much, and I appreciate all the input on this, and we will be looking at this further. Given the time, I think I will not open the phone lines for questions this time either. I will just move on, and those on the phone, please send us your comments and questions in writing, and we will respond and consider them. And I will be turning it over to Cheryl Bullock now, and we will move on. I'll let you introduce.
Yes. Okay, now we're getting ready to deal with another topic, which is found on page 23 of your topic packet. It is called the exertional heat stroke. I have a clinical presenter, Dr. Michael Greenberg, who is Vice President for Medical Affairs at Eagle Pharmaceuticals. He will give us a general overview of the clinical presentation, and then I will present the codes.
Thank you, Cheryl. I'm Mike Greenberg from Eagle Pharmaceuticals. I'd like to thank Cheryl and the committee for having us here today. And I'd like to discuss an overview of exertional heat stroke, characteristics or characterize the patient population, and identify the unmet need in exertional heat stroke, particularly in terms of diagnosis and coding. So there are two forms of heat stroke, passive and exertional, and current ICD-10 codes are unable to distinguish the two forms of heat stroke. Passive, or more commonly known as classical heat stroke, is characterized by an elevated core temperature in association with neurocognitive dysfunction. Passive or classic heat stroke occurs predictably during exposure to higher environmental temperatures, for example, during a heat wave. It frequently affects patients at the extremes of age and patients with comorbidities. Exertional heat stroke, on the other hand, is also characterized by an elevated core temperature and CNS dysfunction, but it is unique in that it is also sudden and unpredictable in onset, and it is triggered by recent exertion or physical activity. EHS is also unique in that it is the most severe form of heat illness. The lesser forms of heat illness, if untreated, can progress to exertional heat stroke. However, exertional heat stroke is often sudden and unpredictable. EHS is also unique in that it's characterized by a hypermetabolic and hyperthermic crisis. So the unique intrinsic heat generation component of exertional heat stroke, when combined with the extrinsic or ambient heat, combines to overwhelm the body's ability to dissipate heat, and consequently it incites a hypermetabolic crisis that carries the disease state forward. Exertional heat stroke is a life-threatening medical emergency. If untreated, particularly if untreated rapidly, it's frequently fatal. Even when treated, common side effects include brain injury, acute kidney injury, chronic renal insufficiency, rhabdomyolysis, coagulopathy, liver damage, and again, in the ultimate extreme, death. anyone who is physically active is at risk for exertional heat stroke. And it's important to note that the level of exertion is relative to the baseline for the individual. So it's relative to their level of fitness and their level of conditioning. And the risks of exertional heat stroke are commonly recognized in athletes and warfighters and other members of the military. However, occupational exposure and occupational risk can be great too. Exertional heat stroke is a risk for firefighters, for agricultural and construction workers, even factory workers, and those who work in foundries. And finally, everyday activity can put one at risk for EHS if the level of exertion is above that patient's baseline, and is not at all uncommon for exertional heat stroke to manifest during routine activities such as everyday yard work or perhaps weekend warriors out with recreation. Despite the identification of risk factors for EHS and a better understanding of the pathophysiology of exertional heat stroke, the incidence of exertional heat stroke in the U.S. is increasing. In the general population, in the last 10 years, the incidence of heat-related injuries, including exertional heat stroke, have doubled. In the military, 2015 marked the highest incidence of exertional heat stroke over the last 5 years. Part of the challenge is that few estimates of EHS have been reported, and those estimates vary widely, and that's largely because of inability to accurately code and analyze the incidence of EHS. So, despite the fact that EHS is increasing in incidence, and despite the fact that, EHS is increasing in incidence, we are unable to identify EHS by the ICD-10 codes, and this has been recognized not only as a challenge clinically, but researchers attempting to analyze the data and describe the epidemiology have identified that as a challenge as well. So in conclusion, EHS is a life-threatening, hypermetabolic, hyperthermic condition which makes it a unique clinical entity characterized by major complications including death, brain injury or damage, kidney injury, rhabdomyolysis and coagulopathy, and the lack of a specific coding and a clear understanding of these codes by healthcare facilities has been cited by researchers and clinicians as an impediment to analyzing and better understanding the disease state. Thank you.
In the interest of time, because we do have several other presenters, I will ask for comment and open up the phone lines at the same time. So I will present, you can stay here though, for tabular modifications for category T67, effects of heat and light. There's a new subcategory, which will be T67.0, heat stroke and sunstroke, with the deletion of the current inclusion terms that currently exist there now. There will be a new code proposed at T67.01, heat stroke and sunstroke, and the previously deleted inclusion terms will be there: heat hypoxia, heat pyrexia, psoriasis, and thermoplegia, with a new code for T67.02, exertional heat stroke, and T67.09, other heat stroke and sunstroke. Yes, Dr.
Jeff Linzer, AAP. We support the addition of this diagnosis code. Living in the Southeast, and I think people in the South, we see a lot of high school players in August suffering this, and I think this is a very good way to be able to track those individuals. So we are supportive of this.
Thank you. Moderator, if you're still there, could you open the phone lines, please?
All lines have been unmuted.
Are there any clinical or coding questions from the phone lines, please? Okay, not hearing in. Okay, hold on.
Very, very quickly. So if we just see heat stroke, it's T6701,
Yes,
and we need to see exertional heat stroke
yes,
to use T6702.
that is my understanding.
And I've never actually seen the term exertional heat illness before. But if we see that term, exertional heat illness, is that equivalent to exertional heat stroke? Apparently, it's not. Exertional heat stroke
I
is.
can't clinically answer that one.
Well,
No.
okay,
So
looking at Dr. Greenbaum, is it?
Exertional heat illness is different from exertional heat stroke.
So-
Exertional heat stroke is characterized by a severely elevated core temperature,
Right, yeah,
CNS.
I saw.
Okay.
Okay,
Yep.
so would we ever see exertional heat illness as the documented diagnosis? Or no, that's more of like a
It-
literature type term?
It could be, and I'll defer to the committee on that, but exertional heat stroke is a distinct clinical entity from exertional heat illness.
Do you know? Would we see exertional heat illness?
You know, from our perspective, it's the same thing. I think the specialists may look at it differently.
Sorry, just
It's okay.
wanted to know if I saw it, what I should do with it.
We'll just have
And we'll double check.
two
as well.
suggestions.
Sure.
At the T6702, would suggest adding a code also for the type of activity.
Oh, okay.
And in the general code also, we would also suggest adding rhabdomyositis as one of the examples. That's very common.
Okay. Okay, not hearing any more. Thank you, Gray, for those comments. And moderator, you could close the phone lines, please. And now I'll turn the program back over to Ms. Donna.
Okay, this is not a proposal that is in your topic packet. This is actually informational, and it's what I will be presenting is a topic that was originally presented in March of 2017, and that was a request for new codes for the electronic nicotine delivery systems. Everybody's nodding their head. Well, based on all of your comments, you all knew that it was definitely coming back. Actually, we had 3 sets of opinions as it relates to this. So this is another one of those issues that I alluded to earlier about there being multiple perspectives on a particular concept. I think there was begrudging acknowledgement that codes are needed. The issue became how to best represent that. But we also received additional comments related to vaping, as it's called, and I think you've all seen it in the newspapers and in the literature lately, and when it's other substances that aren't nicotine, and how do you handle that? And so the issue became not only the proposal that we presented that came to us from the American Thoracic Society, but also based on comments that came in from all of you and other stakeholders as to what to do with all these other things that they are encountering in the emergency departments, that they're seeing in the news. A short list, and I do mean a short list because the list got quite long, was what do you do when the documentation only mentions e-cigarettes without mentioning the substance, or if the provider knows that there are multiple substances that are included in the device. But again, the original proposal was specifically related to the nicotine delivery devices. So we're not presenting this as a topic, and I do have Dr. Scott Maneker here with me, representing the American Thoracic Society, who definitely is the clinical person on this one. Thank you, Dr. Maneker. Because what we would like to do is, before bringing a proposal back to this meeting, we wanted to get additional input from all of you, particularly those of you who are on the firing line, so to speak, in the, actually treating patients, but actually also trying to code what you're seeing in the records. Because when we bring the proposal back, we'd like to bring it back in a more comprehensive way and not just address the one side of the equation that was originally asked for, but to try to address the comments that were made by all of you, because many of you had very strong opinions about getting additional input, making sure that we were covering as much of the waterfront as we possibly could with perhaps parallel codes in additional chapters, et cetera. So with that, I'm going to turn it over to Dr. Maneker. And again, you don't have anything in your handout. We will add a sheet asking you for your input in preparation for the September meeting. Dr. Maneker.
Thank you, Ms. Pickett. It's nice to be back here again. I appreciate the invitation and opportunity to speak. And in appreciation, I'm only going to speak for less than 2 minutes. I'm just going to remind you that electronic nicotine delivery systems are our main focus, both the American Thoracic Society and the American Lung Association. There's widespread and increasing use of these devices nationally and internationally. Most concerning to us are the increasing use of this in the school-age populations. About 11% of high school kids and about 4% of middle school kids currently use these devices. And the data demonstrate that these devices are, in fact, a gateway to using other illicit substances. There's a clear need for diagnosis codes to document the use of these devices, track and perform better population health, identify children and adults using these devices, and provide them relief from dependence upon nicotine. The structure that we originally proposed is fairly easy to use and fits very nicely within the current ICD-10 nomenclature and structure. It could easily be modified, cloned, expanded for a variety of other substances that are used in addition or in lieu of nicotine. As has been mentioned, these devices, you can put almost anything in there. We have fairly widespread support of this proposal. It comes from the American Thoracic Society, is really the convener of a large group, American Lung Association. Last year, the American Academy of Pediatrics and Society of Thoracic Surgeons sent in letters. The Society of Thoracic Surgeons sent in a letter again, as did the American Association for Respiratory Care. Many societies have been in agreement with this, and their letters will be forthcoming during this public comment period. I think the medical community is largely behind this. Again, a very focused approach specific for nicotine delivery that could then form the basis for a variety of other substances and devices going forward. We really think this is the time to start moving forward and have a foundation for this. We don't want perfection and universality to be the enemy of the good or the very good in this circumstance. So thanks for the opportunity to speak.
Should we take any questions or other comments on that right now? I don't see anyone wanting to, so I think we will move forward. Thank you, Dr. Maneker, for being here.
Thank you.
And we'll invite everyone to send in your comments on this also. And I will see if Donna has anything further to say on this also. And if not, then I'll be passing it over to Shannon, and we'll be doing some other topics here shortly. Thank you. Oh, sorry.
Sorry, just one additional comment. Again, we would dearly love to have your comments and thoughts and experiences on this issue with the May 11 deadline for comments to the other proposals. So, thank you.
Okay, our next topic is rheumatoid arthritis and remission, and we have Dr. Robert Goldfein coming to provide some of the clinical background. This topic can be found on page 47.
Good afternoon. In view of the advancing time, I made a snap decision to discard all my slides and make this short. I'm here on behalf of Kaiser Permanente and its national program, along with the Permanente Federation, to propose that we add an ICD-10 code for rheumatoid arthritis and remission. Rheumatoid arthritis, happily, is now a disease for which we have many treatments. When I trained, it was a disease that commonly ended up in severe disability and deformity, loss of work. These days, you don't see that so much, and so our patients are very fortunate, and rheumatologists are very grateful to have an array of treatments that are very effective. The American College of Rheumatology, in recognizing this and and trying to be able to provide better data on this, has actually classified rheumatoid arthritis now as in high disease activity, moderate disease activity, low disease activity, or remission. And there are several tools they've validated that are questionnaires and disease activity measures that they can use to classify people in these states. So we have several tools in which if you have a certain score, you can be classified as in remission. However, we don't have an ICD-10 code for that. So why is this important? There's really two things. The first thing is that on a practical level, we are very well aware that use of disease-modifying agents for RA is a HEDIS and CMS measure. And so health plans are being measured on giving their patients with RA disease-modifying agents, and it's considered the standard of care. The second thing is it's the right thing to do for most patients, and the rheumatology societies have been studying for years how to get people into remission or very low disease activity and how to keep them there. The advent of the newer biologic treatments, in addition to methotrexate, which we've had for many years, has allowed us to get a really significant number of people into remission, sometimes long-term remission. And that's great, but there's a downside to it, which is the medicines we're using are expensive, they're very expensive, and they're actually fairly risky. And so there's naturally some desire to look and say, do we need to keep people on these medicines? Can we taper them? Can we stop them? Some people, especially people who are rheumatoid factor negative, actually will spontaneously go into remission. And one might ask at the end of the day whether they have the same disease, but whatever they have is indistinguishable clinically, so we call it rheumatoid arthritis, often seronegative. So there are people who are on treatment with DMARDs and people who just get better, who are in a sense in remission. And we want to be able to track that. And right now we can't do that. So there are quality reasons to do it. I suspect in the future we might be asked to document what percentage of our patients are in low disease activity or remission. Currently we can't do that, except if people are willing to go into the charts and look at questionnaire scores. So we'd like to have a code that says rheumatoid arthritis in remission so that we can document our quality. We can try to make treatment decisions more appropriate. We don't want rheumatologists treating people with expensive, risky drugs if they don't need it just because they need to satisfy a HEDIS criterion. So this proposal is supported by the American College of Rheumatology. I have a letter from Dr. David Dake, who's the president of this, who strongly supports having a code for this, which will be useful for care, useful for resource utilization, improving quality, and also for future research on treatments for rheumatoid arthritis. Thank you.
Are there any clinical questions for Dr. Goldfein before we go through the tabular modifications? Okay, we will go ahead. Oh, great. Thanks. Okay, so the proposed tabular modifications are at category M05, rheumatoid arthritis with rheumatoid factor, to add a new code M05.A for rheumatoid arthritis with rheumatoid factor in remission. Add category M06, other rheumatoid arthritis, to add a new code M06.A for rheumatoid arthritis in remission. At category M08, juvenile arthritis, to add excludes one note for juvenile arthritis in remission, and to add a new code M08.A, juvenile arthritis in remission, and add the excludes note 1 for the juvenile ankylosing spondylitis. Are there any comments or questions here in the room?
Since the arrival of ICD-10 from rheumatoid arthritis, you can expand amount to a lot from like rheumatoid vasculitis to myopathy to polyneuropathy with rheumatoid arthritis. I'm looking at the ICD-10 code itself. What this rheumatoid vasculitis also under consideration can be in remission with because it's if you look at the code structure itself, it's a lot
Yes.
for rheumatoid arthritis. So if provider document rheumatoid vasculitis with rheumatoid arthritis of the shoulder, now it's in remission, should the code structure be changed and create to that, or?
In that scenario, if
Yeah,
I understood
we
you right,
have-
it would be two codes, one for the rheumatoid, I think you said something in shoulder. Which,
Well, we.
give me
back
the
in-
code number that you're looking.
Well, there are a lot of codes, structure for, like for an instance, I'm looking at right now, rheumatoid myopathy with rheumatoid arthritis of wrist, carpal bone, and so on.
Okay.
So if we are to change the structure, I don't think we should be changed in remission with only 4, because this is unspecified rheumatoid arthritis.
So you would add this code, this would be two codes to capture the
That
condition,
what it
only if what you just described is in remission, would you have this add-on code?
So now the new code would be in remission. This would add secondary to whatever others, right?
Correct, if that condition is in remission.
So then should the instruction be, because I'm telling you, overall structure of rheumatoid arthritis and ICD-10 is very confusing when I'm
Okay.
looking at it.
Okay.
So I don't know the answer, maybe I'm thinking later on, but I'm just saying that, so your instruction under rheumatoid arthritis in remission should be also with other rheumatoid arthritis?
Would that, okay, if that makes
I'm
it
just
clear-
asking, would that going to be that case for us to code?
If that clarifies your concern on whether you would have two codes to capture the rheumatoid arthritis.
In remission, and the patient carry rheumatoid vasculitis.
Right, in remission, you would have the two codes.
Right.
Yes, so that would definitely need some type of instructional note to clarify that.
Right,
point.
that was my thought process, yeah, yeah.
Okay, I follow that.
Okay.
Thank you.
All right.
So, following up on Teen's question, I assumed that the fact that it was in remission was took precedent over whether it was Felty syndrome or, which is the M5.0, or any of the other types. M5.1 is the rheumatoid lung with rheumatoid arthritis. So I was assuming that if it was in remission, I wasn't going to go to the specified codes. I was just going to use the M05.A.
And my understanding is they would need two codes, one capturing that type of arthritis.
The specificity.
Correct.
And then another code for the fact that it's in remission.
Correct.
Okay, then we need notes about that, that's all.
Okay, instructional note, kind of tying back into the first comment, yes,
Right.
okay.
And then the other point I just wanted to make is I think it's a very good idea to have additional codes for whether it's in remission. We have plenty of other conditions in ICD-10 where we specify in remission. So for example, it's not just like the leukemias and lymphomas, but also alcoholism and that, plenty of other conditions. So I do support additional codes for in remission.
Okay, and I'll make a point to be sure that we add some type of instructional note for that clarification. Yes?
Hi, my name is Tawana McIver. I'm with LabCorp. I have two questions. Is this code meant to capture the fact that the condition is in remission, or the fact that the rheumatoid factor is in remission? That's the first question. The second question is there any consideration to having codes to then say that this condition or finding is in relapse?
Okay, the first question, it would depend on, there is a section of codes under MO5 that cover rheumatoid factor. However, if you go to the MO6, those are the block of codes that are without the rheumatoid factor. So I believe that would address whether or not you're going to be in the right place when you pick up this additional code for remission. Your second question regarding the relapse, I'm going to let Dr. Goldfein speak to.
Yeah, that's a good question. I want to comment on that. First, the criteria for remission do not include rheumatoid factor status. It's absolutely clinical criteria based on swollen and tender joints and patient assessment and physician assessment of activity. The second thing is, just as a practical matter, if someone has a rheumatoid factor and they're being treated and have absolutely no symptoms, they will still have a rheumatoid factor.
Okay.
And we just don't pay attention to it.
Okay, thank you.
I just have a comment that I know you didn't get to present your slides, but is there any way for us to have access on the website so that we could see your slides and the other presenters? Because
Actually, for this one, there was no slides.
oh, I thought he said he, in the interest of time, you weren't going to present them.
He said it was a little white lie.
Oh.
But I can definitely check on the other slide decks that were presented. We can definitely take that back. Thank you for that. Something probably very, very helpful. Okay. Moderator, could you please open the lines up for any comments or questions?
All lines have been unmuted.
Any questions or comments from the online? Okay, hearing none. Moderator, if you could please mute the lines. Thank you, Dr. Clark. We will move on to the next presentation, and that topic is drowning, submersion occurring in natural bodies of water. And it's on page 17, and we have Officer Brewster who will be coming up to provide some background on this issue.
Thanks very much. How many doctors are left in the room? Oh, great, you're outnumbered. So, for a short period, I worked as a ski patroller at Vail, Colorado, and in the evenings, I worked at hosted a restaurant there. It was very popular, and people came in and wanted tables. It was a first come, first serve. And whenever someone came up and told me their name was Dr. So-and-so, I asked them to clarify. They said, yes, I'm Dr. So-and-so, and I typically put them down at the end of the list. So I guess the doctors got their revenge today, and I'm at the bottom of the list, so that's fine. Okay. I'll try to make this as quick as I can. I'm with the United States Life Saving Association. I'm a retired lifeguard chief for the city of San Diego. I've been involved in drowning prevention all my life. Currently, I work or volunteer my time as the liaison officer for the United States Life Saving Association, the moderator of Water Safety USA, and I'll talk a little bit more about that, and president for the Americas region of the International Life Saving Federation. I wanted to put up the definitions of drowning here because drowning is commonly used as a term for a fatal event. But the true meaning of drowning is that it is a process that can be interrupted by rescue, or people can end up with long-term effects from it, or just walk away completely healthy. So that's the way those outcomes should be defined. It's the third leading cause of unintentional death worldwide, leading cause of unintentional death in the U.S., and an even more prevalent cause of injury, and that's what I'm here to talk about today. For every child who dies, 5 receive emergency department care for non-fatal submersion injuries, and this is the important part from my perspective, is that a lot of these are lifelong debilitating injuries where kids come from backyard pools or from some pond or whatever, are resuscitated but survive in a vegetative state. So you see down in the second bullet that 6,300 emergency department visits and 2,500 hospitalizations for non-fatal drowning. Drowning obviously primarily affects healthy people, like car accidents, people who are completely healthy in most cases and are suddenly affected by drowning. But most importantly, it's completely preventable. So a person who is completely healthy could suddenly die in a very short period of time, or that process could be interrupted or completely prevented. Targeting resources to drowning requires targeted data on where the drownings are occurring in the U.S. And the current ICD-10 codes really don't drill down to those locations. More than half of the fatal and non-fatal drownings in the U.S. Among those 15 years and older, as you can see, occur in natural water settings. In fact, it's about 57% of the drowning deaths that occur in those natural settings, and that's why it's important that we have some specificity there. These are some broad terms for different open water settings, natural water settings, oceanfront, tidal bays and waterways, Great Lakes, ponds, lakes, reservoirs, rivers, flooded areas. And I can talk later about why we drilled down to those specific locations, because I think I might need some help from some of the coders in the audience about how we came up with those areas and to explain a little bit more about why. But our request then is to add some more specific codes to identify those natural areas. I wanted to give two examples of why this is going to be important to us. I currently chair an organization called Water Safety USA. As you can see, it's composed of all kinds of groups: the American Academy of Pediatrics, the U.S. Army Corps of Engineers, National Park Service, Coast Guard. What we're trying to do right now is to put together a national water safety plan. And to do a good job of it, we need specifics on where these incidents are happening. And right now, those specifics aren't readily available. Second example is rip current safety. The National Oceanic and Atmospheric Administration and my organization, the United States Life Saving Association, have been involved for almost 20 years trying to promote rip current safety. That occurs at oceanfront beaches. But there's a lack of specificity in the data out there about how many drowning incidents, whether fatal or non-fatal, are happening at oceanfront locations. It's just not there. So what would be the benefit of this? Better understanding of what the problem is out there. The ability to do a better job of targeting resources, especially in that National Water Safety Plan, but also locally and nationally. Increasing prevention resources. The data is essential to get people's attention. Benchmarking of successful strategies. If we put together that National Water Safety Plan, we need to have some sort of a baseline and then see how we're doing, figure out where we need to adjust our targeting, and ultimately a reduction in drowning, injury, and death. And that's my story, and maybe we can look at those codes and I can explain to you a little bit about the question I would have for the coders about what we came up with.
Okay, Ms. Schroeder, I see you're at the
No, I
mic.
just have a coding comment, that's all.
Okay, so they're going to bring up the coding tabular,
Okay.
the tabular modification screen.
Can we have the CDC presentation up there? They said it would take a few seconds
Oh,
to show up,
okay.
and there it is.
Okay. Okay, so I'll go ahead and walk through the tabular modifications, and then we'll open the floor up for both clinical and coding questions.
Yeah, I just have a question, but go ahead.
Okay, okay.
I'm not going anywhere.
Okay. Okay, so we would be creating a new subcategory, W69, for accidental drowning and submersion while in natural water. The proposal is to delete the inclusion terms that are currently existing there for accidental drowning and submersion while in lake, in open sea, in river, and in stream, and to create a new code W69.1 for accidental drowning and submersion while in open sea, a new code W69.2, accidental drowning and submersion while in ocean bay, with the inclusion term for while in inland waterway, a new code W69.3 for accidental drowning and submersion while in oceanfront water, new code W69.4 for drowning and submersion while in the Great Lakes, a new code W69.5 for accidental drowning and submersion while in lake with inclusion terms for in pond and in reservoir, a new code W69.6 for accidental drowning and submersion while in river with the inclusion term for while in stream, new code W69.7, accidental drowning and submersion while in flooded area, and new code W69.8 for accidental drowning and submersion while in other natural water. And Ms. Yoder?
Okay, well, not only was I breached, I was married in Volo Bog, okay? And so I just want you to understand, bogs are obviously natural bodies of water with
bogs.
no,
Okay, got
with
it.
no drainage.
Yep.
Okay, so I come from the Kettle Moraine area, and so we have bogs and swamps, and we have other places where water is naturally right there. And, okay, so so I'd like a not otherwise specified or an other specified, and because.
That's the last one, or intended to be.
Point 8 for the other natural water?
Okay, how about a not otherwise specified?
Not
Oh,
otherwise
okay.
specified.
So you've got the bogs and the swamps, and you've also got the kayakers on the Chicago River that are found in Lake Michigan, okay? So I'm not really sure where they inhaled or tried to inhale the water, but, you know, you've got to have something, okay? So like the Marines, we have the littoral region, so there's got to be some kind of, okay, never mind.
No,
I'm just bringing
look.
this stuff up.
No,
because-
it's good input, but look,
Okay.
I've recovered a lot of bodies.
Yeah?
Seriously.
Not in the Great Lakes? Oh,
No, just,
okay.
yeah, in the water. And, yeah, sometimes you do not know where the accident happened.
Right.
To answer your question. So
Right.
that's just a
So-
reality.
Right.
I mean,
I'm just saying we need a not otherwise specified, and we need something so that we can put those kinds of things down, because we just need a .9, you know?
well,
0.9?
I have no worries on that.
Okay.
That was really
And-
what the intention was of 69.8.
Okay, so, and then the other natural water would be the bogs and the swamps and those kinds of places, right? Okay.
Yeah, I live in the Pine Barrens in New Jersey, so we got plenty of
Like she
swamps
says.
there.
Yeah,
So-
yeah.
Although I got married in shul, for crying out loud, it's not a bog.
Well, the second time was the courthouse, but the first
okay,
time was the bog.
So maybe we need the W69.8 to have inclusion notes for bog, swamp, that kind of thing. I mean, if we're going to get serious about making distinctions here, then let's make them. And then we need to add W699 for, you know, unspecified.
Okay, could I just ask my question while you're still there? Because this is a separate question. We were trying to figure out which order we should put these in. And here's why this is complicated. So the first one is drowning and submersion while in open sea. Then we get into ocean, bay, and inland waterway. I think that's understandable. But the key area that we're concerned about for rip currents is 69.3, which is oceanfront water. So my question is, from a coding perspective, if open sea is first, and this occurred just off of a beach, is the coder likely to say, oh yeah, that was open sea, coded, and not get drill down to the third one, which is very important? Most of these are happening near shore. That's my question.
The thing is, you're going to put in a little thing under .3 that says rip current, and that's, the coder will just zoom right in on that. So you've got, like it says, accidental drowning while in a pond. You need to put under that oceanfront water, accidental drowning due to rip current. And bingo, they'll know exactly what to
Yeah,
do.
it's not only rip currents, though. You know, oceanfront could be somebody gets hit by a wave, somebody is scuba diving, and, you know, whatever. So the point is, this is a differentiation between near shore and offshore when you're talking about oceanfront. And I'm just wondering about the grouping and order here. Is it likely to be misinterpreted, or should the
No,
oceanfront be first and then open sea after that?
I think you're worrying about this too much.
Okay, well, I just want to make sure the data's right. All right, sorry, I didn't mean to want to interrupt whoever had something to say, so.
No, because, I mean, we'll read through it, and if you have things like riptide or something, that
Rip current,
really, those
yes.
are the kinds of things that really help us a lot.
Okay.
We're not going to go up this saying, okay, we're out in the ocean, and then we're coming in, and then we're in the bay, and then we're in the ocean front, and then we have to go up over the Niagara Falls to get to the Great.
Okay, but understand, when you said I'm drilling down too far, you're the one who came up and suggested bogs.
There are a lot of people, okay,
That was all I
bogs
had
and
to say.
swamps, because
Okay.
I'm just, no,
Okay.
I'm thinking that's a bigger.
Thank you. So any other comments from here in the room?
I was just, I mean, when you asked about that, I would have gone to W69.3, But if you want to, why can't you include short, near, water by shoreline? And then that way it'll be clear. Under W69.3, you said you want to make sure that the coders
Yeah,
know
we
that
just
it's
need to
the
make sure
shore.
we're talking about ocean. So we're differentiating ocean from Great Lakes from ponds. And so,
Yeah, I'm talking about W69.3. You said, will coders know what oceanfront water is? And you said that that means by the shoreline,
yep.
right?
Yep.
So that's what I would have thought too, but it might make it clearer if you're,
So we need to say, have a subcategory under the oceanfront that says something like near shore.
inclusion note.
There.
And then the other thing I wanted to say is for W69.5, why can't you do submersion while in lake, comma, pond, comma, and... Or reservoir. Yeah, reservoir, well, and means and or, but...
Well, keeping with what's currently existing, these each have their own separate line. If you look under the intentional drownings, assault drownings, they're kind of already sectioned out by each one of those lines, so therefore we wanted to be consistent with what was currently there in other codes. That's the reason, it's just keeping it consistent with what was currently existing.
I was just trying to save a page.
Yes.
I'm taking a little bit different approach here. From coding's perspective, so we would have an accident code with a drowning, right? And then a type of drowning, patient be on his jet skiing, and a place of occurrence. Why don't we add more of this when we already have coding exist? So you have a place of occurrence category to tell where this location exists, right?
Yes.
Okay, on the river, we have that.
Yeah, but the place occurrence.
So that is so under Y, I believe. Was it Y?
Yes, the Y codes. Keep in mind that when you do the place occurrence, and this is kind of the reason why we chose this, especially once we found out that they were looking at accidental drowning. When you're doing your coding and your number of, lines allotted for coding, place of occurrence when it comes to precedence would not always be one that's going to be at that top ranking. So we want to...
This would not be a top neither.
Well, this will get you higher because this is actually covering the intent and the mechanism as opposed to the place of occurrence, which is like, what, third on the list when we start trying to put it in order?
It would not. What happened is that if the patient comes with near drowning, went to respiratory failures, or the kind of condition, so the condition go first. So
Yes.
we would code a T code for accidental.
Okay.
And all the things shift to the bottom.
And your place of occurrence is going to be near the bottom of that list, and
All
this should
this,
be
yeah.
one or two above that, so.
Unless you instruction us to have a system to bump all this code up. But that's what I'm saying is that we already have the structure exist. Why are we adding more of the category and when the structure already in place of our coding drowning, the cause, followed by conditioned, and then a place of occurrence. Okay, the patient can be playing on a jet ski, so we
Yes.
describe that, right?
Yes.
And then a place of occurrence, which is called with a Y. So now you add something more, we're going to add more code to it, but it's going to be more lengthy for you. And this code for us is really bumped up to the top.
This one should be bumped up to the top, and your Y code should actually be coming after this
Because
code.
it's W external cost, whoa.
If you look at the coding guidelines, you should be reporting this code before you're actually listing your place of occurrence.
Right.
And your status.
But the condition is south.
The condition.
Which is like respiratory failures, cardiac arrest. But if you want us to cut it first, and there's some kind of instruction come out for us, and we can do that for you. I'm telling you that any external cost, somehow we get bumped to the bottom. But we can only report 30 codes at the top.
Okay, just as a reminder, before I turn it back over to Shannon, in the coding guidelines, yes, you would always code the principal diagnosis being the injury that is associated with the near drowning. However, in the section of the guidelines that talks about the assignment of the external cause codes, it tells you that it requires 3 codes: the mechanism, the place of occurrence, and the activity. And then for those who remember what's on your UB04 or your electronic claims, there is room for 3 external cause codes, but one of them, I believe, is still called the principal external cause code, most related to the actual injury code. So it would be your W code. It would not be your place of occurrence code, nor would it be your activity code. And I don't have the guidelines in front of me, but there's also a section in the guidelines that talks about if you are limited in the amount of space that you can report external cause codes, again, the primary or principal external cause code would be that, which is the mechanism that is more closely associated with the actual injury from the near drowning. The principal external cause code would not be an activity or a place of occurrence code. So that information is already in the coding guidelines. So we weren't trying to repeat all of that within the actual tabular notes, because you have other ways to figure out what this proper sequencing is. So, and with that, I'll turn it back to Shannon.
Okay. Well, no one's at the mic here in the room. Moderator, would you please open the lines up for any comments or questions?
All lines are open.
Any comments or questions from anyone on the lines? Okay, hearing none, if you could please mute the lines. Thank you, Dr. We will move on to the next topic. And I'd like to ask Dr. Alan Mendelsohn to please come up. Dr. Mendelsohn will be giving the clinical presentation for Acne vulgaris, and the topic can be found on page 10.
Thank you very much for inviting me. Just in terms of disclosure, I am employed by Sun Pharmaceuticals and have been employed in the past by Janssen Pharmaceuticals and Pfizer Pharmaceuticals. The topic of acne, of course, is probably not as rare as some of the other diseases we've discussed today. Probably 90% of people in this country, depending on their age, have experienced acne. It is a very common disease, probably one of the most common diseases. It's pretty straightforward to recognize and diagnose clinically, whether it's open and closed comedones, more colloquially known as whiteheads or blackheads, papules, pustules, nodules, and such. Affects most of the time, affects the face, about 60% of the time affects the trunk, and of course can lead to all sorts of post-inflammatory hyperpigmentation. So the issue arises, however, how do you clarify or categorize acne? And this problem has been going on for 30, probably, or 40 years. This is a paper from 2013 that attempted to put together about 13 different papers in terms of discussing the potential ways to categorize acne. And as you can see here on this slide, here are about 18 of the probably 40 or 50 different categories, including one by the FDA that you can see sort of towards the bottom in terms of descriptions. And they vary based upon usually things like inflammatory versus non-inflammatory components, whether they're found on the trunk as opposed to just the face, the number of the lesions, and the distribution of the lesions. So the issue that we face as a society, as a pharmaceutical industry, is though there are clearly large numbers of studies that have been undertaken to try to qualify or quantify acne. There's been no singular system that's really worked and has been acceptable to all practitioners, to the point where, in fact, though acne is a multifactorial disease with a wide assortment of severity, there is, to the best of our understanding, only a single ICD-10 code, L70, for acne vulgaris. Though, as I will show you in actual clinical practice and in the verbiage used by clinicians, various treatment modalities are used, and in fact, physician gestalt is used to define whether a patient has mild, moderate, severe, or very severe diseases. Clearly, as you know, there are multiple examples. These are just two of the examples where severity of a disease has led to differential coding within the ICD-10 code. So for chronic kidney disease and ST and non-ST segment myocardial infarction based upon location, even though in many cases the location of the myocardial infarction and the treatment is identical regardless of the location of where the myocardial infarction occurs. The FDA, obviously in trying to define the criteria for clinical trials for the pharmaceutical industry to design, put out this guidance document in 2005. Of course, it's a guidance document, not the law, as well as large dermatology communities such as the American Academy of Dermatology. And as such, categorization of acne by AAD and FDA do point to a general consensus that revolves predominantly around physician interpretation. And you can see that in the bottom, and this is copied verbatim from the FDA guidance, that a number of acne grading systems have been described with inherent difficulties with regard to use. Such difficulties include inadequately defined grades of severity and excessive or excessively small differences between grades to be evaluated objectively. And they recommend using, as you can see, an investigative global assessment scale that may be useful for assessing overall acne severity. And in fact, looking at the document itself, the FDA views severity of disease based not on numbers of lesions or even location, but whether they are or not inflammatory, and not even using, segmented language, but using much broader language like few lesions or rare lesions or no more than one small nodular lesion or no more than a few nodular lesions for group 4, which is obviously the most severe. The AAD, the American Academy of Dermatology, has looked at this topic for years, and this is a paper from 2003 and a more recent guideline paper from 2016 that comes to a relatively similar decision. The FDA guidance and the 2016 guidelines from the AAD the guidelines, in fact, used 17 acne specialists, 1 general practitioner, a pediatrician, and a patient. And the purpose of the guidelines was to try to come up with answers to the questions around diagnosis and treatment. And you can see that even within the AAD guidelines, I don't know if you can read this, the AAD can define and does define acne based predominantly on the physician's gestalt, because as you can see, the number of comedones, whiteheads, blackheads, is few to many versus numerous and extensive, or large and very extensive for severe, but there's really no number or other guidelines. It's all based really on physician healthcare provider interpretation. And so, in fact, this brings to mind the very famous quote from the late Justice Potter Stewart when he was asked about pornography. He said, "How do you define pornography?" And he said, "I know it when I see it." And in fact, that's in essence how acne is treated now by the general medical community. So that you can see, even though there really are no specific guidelines, joint counts, for example, in the rheumatological conditions, or other conditions, physicians and the treatment modalities have evolved for different treatments for mild, moderate, or severe disease within their own important roles, but also having more follow-up. So, for example, the more severe patients who require oral antibiotics or oral isotretinoin will obviously require more follow-up because they require more laboratory findings. They also obviously are being treated with medications that have a black box against pregnancy, versus the milder cases, which are using topical benzoyl peroxides or topical antibiotics that don't have that level of follow-up by the medical community, and therefore also don't have the same level of severity and requirement for follow-up. And so again, within the AAD, they come back to the same finding that the FDA did, which is that clinicians may find it helpful to use a grading classification scale encompassing numbers and types as well as disease severity to facilitate therapeutic decisions, but no universal grading system can be recommended. In a more recent paper in 2017, and this is a global paper from 36 dermatologists from 27 countries using the Delphi method, fully understanding, however, that though no official guidelines exist for these classifications, physicians can and do define the disease based on mild, moderate, and severe disease
based on simple appearance and therefore apply different treatment modalities to the disease. So this is mild, moderate, and severe disease, for example, and these are more examples of nodular conglobate disease, which is considered very severe acne. And so it is our suggestion that L70, though it covers all of acne, may be somewhat inadequate to cover all the different forms and severities of acne that are currently seen and the different treatment modalities. Thank you very much.
Please. Are there any clinical questions before we go over the coding?
Yes, Dr. Mendelsohn, for someone who has sat all day listening to all of this, I would like to do anything for you. I mean, I applaud you, sir, for sitting through all this all day. But I need to ask you a clinical question, and I want you to know in advance it's a trick question. Is there, I can't tell from your slides, is there or is there not an accepted consensus on what constitutes mild, moderate, and severe? And as I said, it's a trick question.
I think it really is a trick question because, in fact, if you look in the literature, so for you to ask me, of 100 patients, what proportion of them have mild disease, moderate, or severe disease, that would be totally investigator dependent because the investigator who wrote the paper will have defined for himself or herself what the severity is. So, for example, for the one paper I was able to find, it's about 25% of patients have mild disease, about 48% of them have moderate disease, and the remainder have severe disease. But that's based upon the criteria that they have. It's more the gestalt and, in fact, the dermatological appearance of the condition and how severe, for example, the side effects might be. So the depression, the self-esteem issues might also define that. It also depends on the severity and the location. Very similar, for example, to other skin conditions like psoriasis. So a patient, for example, who had plaques all over their face but no place else on their body, one would not technically consider them severe if they had less than body surface area of 10% or a PASI of 12, which is the common coding used in clinical trials, and yet every physician, every healthcare provider would consider that patient to have severe psoriasis. So I think it's the same thing here.
Well, the reason I asked and the reason it's a trick question is because yesterday and today we had a number of presentations where basically clinicians were saying that we need a code so we can drive the diagnostic criteria. And in fact, that's not how it works. It works the other way around.
Exactly.
The diagnosis drives the code. And so if there is no clinical consensus on what mild, moderate, and severe means, the data's not going to be worth much. So like I said, I want to say, I love this, just go ahead and do it, because you sat here all day, but it doesn't seem consistent with how ICD-10 coding is set up.
Sure, but as I said, if you look at, for example, the coding for myocardial infarction, and by training I'm actually a cardiologist, so I can relate to this, is that yes, the different locations of the coronary artery occlusion can have more severity, but for example, if you went into the cath lab and you stented a left anterior descending artery, it's exactly the same procedure as stenting the right coronary artery, and yet they have two completely different codes. So,
I know, and there's some validity to that. But the point is that I know from the documentation and the testing that's done, I know which coronary artery is occluded, and I know what percentage the occlusion is. But here you're asking us to use what's essentially an adjective, a descriptive term. So if we're going to use a term like mild, moderate, and severe, there really needs to be some definition that's consistent across physicians.
Right, and again, in fact, one could argue it's just the opposite, that in fact the severity is dependent upon the medications that are used by the physician, and sort of the choice of the gestalt of the healthcare provider in determining whether they are willing to use the most toxic agents that are available versus the least toxic agents that are available may, in fact, by definition, define the severity of the disease. So, for example, if you have a patient or a healthcare provider who wants to provide isotretinoin to a patient very early in the disease process, that HCP, almost by definition, is implying that that patient has severe disease.
That's
The
the
bottom
problem.
line is that there's no other way, in
Almost
fact,
by definition.
through the CMS system to define, to your point, the flip side of your question, which is there is no way through the CMS system to currently define who has mild, moderate, or severe acne, and the implications of that.
It may just be that there isn't a way to do it. Okay, but
sure,
we'll see where it goes.
Yep.
Okay, so for the tabular modifications being proposed, it's at category L70 for acne, and the request is to expand and create a new subcategory, L70.0 for acne vulgaris, and it would be capturing unspecified, mild, moderate, and severe, with the inclusion term for acne vulgaris, NOS, at the proposed new code of L70.01. Any comments, questions here in the room?
Just a general question. Has the American Association of Dermatologists reviewed this proposal?
Yes, they have, and we are waiting feedback. They actually had a meeting and a couple other things going on, but we are waiting that feedback, yes.
Thank you.
Any other comments or questions here in the room? Okay, moderator, could you please open the lines for any comments or questions?
All lines have been opened.
It's McNicholas from the American Academy of Dermatology. Ms. Lamptey, thank you for giving me this opportunity to make a comment.
Thank you. Go ahead.
We did respond, and I think the email hit your inbox on Monday, so a little bit too late for you to have reviewed it. And the position of the American Academy of Dermatology is that, yes, we would like to see a better classification of L70 as a category. However, using the words mild, moderate, and severe seem a little bit too simplistic, so we did multiple reviews of literature, some of which was presented today, as well as reviewing the ICD-10 beta data. And what we found in there is that the ICD-11 has attempted to make this classification a little bit better than what is being proposed today, in the sense that they have included clinical patterns of the condition as a better classification or expansion of the code family. So the Academy has provided that information for your review, and that's what we would support. This is working between the ICD-10 work group as well as the Clinical Guidelines Committee, which have approved that instead of using the words mild, moderate, and severe, they would rather see an extensive review of the whole code family to include clinical patterns.
Thank you. Thank you so much for dialing in, and I look forward to reading the response, but I think that everyone would appreciate and can really appreciate the fact that you dialed in and we heard it here at the meeting.
Thank you.
Any other questions or comments from the line? Okay, hearing none, I'm going to turn the podium back over to Dr. David Berglund.
All right. And next, we're going to look at traumatic brain herniation, and this is on page 51 in your handouts. And we're getting near the end here of all the things we've been covering, so we've made a lot of progress. And I'm glad to still see a number of you here till the end of the day. This is good, I think. The people who are really sticking with it, glad to have you all here, yes. So traumatic brain herniation. Well, first, brain herniation is something that happens when brain tissue or cerebrospinal fluid or blood vessels, other tissue in the head, are moved or pushed from their usual position inside the skull to where they're out of position. And then pressure that's resulting in such movement can be due to brain swelling from a head injury, from a stroke, a brain tumor, an abscess, from hydrocephaly, or even some other underlying causes also. And this herniation, brain herniation, can occur between different areas inside the skull, those separated by a rigid membrane like the tentorium or the falx, or to the outside of the skull through the foramen magnum or through a craniotomy opening or through some other defect, whether it's traumatic or congenital. And traumatic brain injury is one of the most common causes of brain herniation. And different parts of the brain can herniate, and these may each cause different clinical syndromes. A subfalcine herniation occurs when the cingulate gyrus herniates under the falx cerebri, resulting in a midline shift. An uncal herniation involves the medial temporal lobe herniating through the tentorium. This is also called a lateral transtentorial herniation. A central descending transtentorial herniation occurs with a downward herniation of both the temporal lobes through the tentorium. There can also be an ascending transtentorial herniation in the opposite direction with the cerebellum pushing up through the tentorium. A tonsillar herniation is what happens when the lower part of the cerebellum and the brainstem herniate downward into the foramen magnum. For that matter, also, we'd mentioned that you can have a herniation through a craniotomy opening or other defect, and that's called a transcalvarial herniation. Now, brain herniation can cause a number of signs and symptoms, for example, pupillary dilation. It can sometimes be fatal in a relatively short time if it's not treated. Presence or absence of brain herniation is a very important thing clinically. Non-traumatic brain herniation is currently coded using G93.5 compression of brain, but traumatic compression of brain is excluded from there to some of the codes at the S06.2 for diffuse traumatic brain injury and S06.3 to focal traumatic brain injury. So ultimately, when you have traumatic brain herniation now, essentially the code gets lost in a code that just tells you there is a traumatic brain injury, and you completely lose the information to the effect that there is herniation and potential resulting injury and problems from that. So now there are other codes within category S06 that can also be related to brain herniation, but it's not feasible with our current codes to differentiate brain herniation that's traumatic in nature. Traumatic brain injury is an area of active and important research, and having codes for traumatic brain herniation has the potential to help future research that could advance care of such individuals who can be incredibly ill. And a request to provide specific codes for traumatic brain herniation has been received from the University of Utah Health and Neurology Department. Let's look next at the tabular modifications we're going to propose here. And again, this is on page 52 for those following along. At S06, intracranial injury, 0.8, other specified intracranial injuries. We're proposing a new subcategory, S06.83, for traumatic brain compression, with an inclusion term for traumatic cerebral compression. And we would also put in a code first note to code first the underlying traumatic brain injury, which would include some of the other codes at S06 that are listed here, whether diffuse or focal, or related to a hemorrhage. We'd want to include those particularly. Again, this is a such as note, I will note, so there could be others that could be important in traumatic brain compression. We would propose a new code, S06.830, for traumatic brain compression with no herniation. We'd have an inclusion term for cerebral there also, so brain or cerebral in this case we could use more or less equivalently. A new code, S06.831, for traumatic brain compression with tonsillar herniation. And we would have inclusion terms there for cerebral, cerebellar, and brainstem, and also the term coning. A new code, SO6.832, for traumatic brain compression with ascending transtentorial herniation, with an inclusion for the cerebellar compression. Also, reverse coning would be there. A new code, SR 6.833, for traumatic brain compression with subfalcine herniation, and cerebral being included there also. And you'll remember this was one that involves a type of midline shift, and the cingulate gyrus is herniating under the falx cerebri. Next, a new code, SO 6.834, for traumatic brain compression with central transtentorial herniation. And this would be the descending transtentorial herniation. Also a code for cerebral as an alternative to brain there, an inclusion term. And then a new code, SO 6.835, for traumatic brain compression with uncle herniation. Also using the term cerebral instead of brain, and also instead of uncle herniation, the term lateral transtentorial herniation. Next, a new code, SO 6.836, for traumatic brain compression with transcalvarial herniation. Also an inclusion term with the term cerebral instead of brain. And new code SO 6.838 for other traumatic intracranial compression, which would include traumatic brain compression with other herniation, and traumatic cerebral compression with other cerebral herniation. And finally, a new code SR 6.839 for unspecified traumatic intracranial compression, which would have also included traumatic brain compression with unspecified herniation, and also the term cerebral as an alternative there. Any clinical or coding questions about this proposal?
Teresa Rahanick, IMO. I think that's quite a lot of codes, and the documentation, I think, will be difficult to get the exact place it's herniated. So my personal feelings only have a couple of codes, but if you do go forward with this, I think the descriptor on S06-830 should be traumatic brain compression without brain herniation instead of with no herniation. And then the 838 should say other, for whatever reason you switched from brain compression to intracranial compression there on the 838 code, that you should probably continue the same other traumatic brain compression and then include with other brain herniation, because that descriptor no longer, it drops the herniation, which is what you're trying to include in the includes note. And then the same comment at S06-839 for an unspecified traumatic brain compression without herniation.
Okay.
With unspecified brain herniation. Yep, the title needs to come all the way through. Thank you.
Okay. Thank you for that input. And Linda?
Yes.
Agreed then, huh? Okay. Okay.
I do have a clinical question. So is there a difference between compression and herniation? Because non-dramatic one don't have one code.
Okay, and
But
yes, there can be compression without as much significant herniation, and that basically if there's swelling and pushing outward against the skull in any case, then there can be compression just from that. The herniation implies a certain amount of movement past some type of either moving through a hole like the foramen magnum or past a rigid membrane like the falx or the tentorium. So basically, the herniation implies that there is some movement due to the swelling and that that's leading to pushing against some other particular structure, while you can just have compression just due to swelling and expansion.
Okay, I believe back in ICD-9, we have two separate codes for non-dramatic, one a compression, another one a herniation. So will you reconsider the non-dramatic one to be that way too, structural, is it herniation? Without
So,
compression?
question whether we should expand the non-traumatic, since we've got a code for it, but we don't have a whole lot of potential options like what we're proposing here for the traumatic.
So right now we're under one code, am I correct, for the non-dramatic? That would include compression?
Yeah, the G93.5 compression of brain basically is where the non-traumatic brain herniation goes now.
Does that include compression and herniation?
That would include both compression and herniation.
Would you consider expand that code out?
We could.
Thank
We did
you.
not have that requested at this time, but we could consider that.
Do you want me to put in a request?
Certainly, well, if we
For
certainly be willing to hear
2010.
that. But that's something we can look at in addition.
Okay, thank you.
Okay. Other comments or questions or thoughts on these? Operator, could we have the phone lines open for comments?
All lines are open.
Any comments about the proposal that we've just discussed there on the phone lines? Hearing none, I will ask you go ahead and close the phone lines again, and we will wrap things up on this, and I will pass the podium over to, can we go ahead and have the phone lines muted again? And we will next be doing the addenda, and I will turn the podium over to Tracy Ramirez.
Okay. Well, before I start, I just want to say that these changes, proposed changes, a lot of this is coming into our inbox requesting. So as they come in, we try to get them into the addenda as quick as we can. So in lack of time, I'm going to not cover everything, but I do want to cover some key points. There are a lot of code changes, just because they were directing to the wrong code, so we're correcting that. And I know Darlene is still here, so I know you were talking, you requested, not requested, but you asked about the lupus NOS, and in fact, we are going to delete that from the excludes node at A18.4, as well as we're going to use the full code title for systemic lupus erythematosus. And at B97.4, we are going to add the abbreviation of RSV under respiratory syncytial virus as the cause of disease. Disease is classified elsewhere. And as well as down at J12, J20, and J21, we are as well adding the abbreviation for RSV for pneumonia at J12.1, J20.5, RSV, acute bronchitis due to RSV, and acute bronchiolitis due to RSV at J21.0. Do you want me to get your questions now?
Okay. I just want to mention about the lupus, because now my memory's a little fuzzy, but I think what I wrote in is that in the index, there's no default for like lupus, not otherwise specified, because right now, when we get lupus, because a lot of times the doctors, they just write lupus in the chart. They don't say what kind of lupus. So we have to query on every single one. And, on, like, especially the outpatient, like ERs and things like that, we never get a response.
Right.
So basically, we just don't add any code at all because of it.
Yeah, and the problem with that is, no, go ahead.
I didn't realize that there was lupus M32.9 even under A18.4. Or maybe I did. You said I wrote in, so I guess I did. I don't remember. Sorry. So there is no default. Am I right?
Correct.
By you deleting that.
Yeah.
Okay.
Correct.
All right.
Yeah, there is not a default, and we did talk about this and go around about it a little bit. Essentially, for lupus erythematosus, there is a default to L93, the discoid lupus, and then for, of course, systemic lupus erythematosus, it's the M32. There had been a default in 9cm for lupus that was going to the systemic. Given that the lupus erythematosus by itself goes to the skin version, it would seem that that might be an alternative, but we were somewhat uncomfortable trying to set a default for this. I'm not sure. I suppose you could comment on whether it usually ends up being systemic or whether it is a mix of both the discoid skin and systemic, or what the case is. But we do understand that in some cases for, more severe disease, the systemic may be more common, but certainly they could mean either one, and that's part of the problem.
And on the inpatient side, the responses are typically the systemic. On the outpatient side, it's like, we don't have time to answer this. We just don't get a response, so.
Okay, it's awkward. Well, and given that these are in separate chapters, it would be awkward to try to create a default, although we're open to suggestions or comments on that further if you wish, but that's...
And it might be on the outpatients that, like, patients are coming to the ER for something different, and that's just, part of their history. So a lot of times the ER doctors, they may not even know what type.
Okay.
Linda?
Yes, I wanted to ask about the B97.4 for respiratory syncytial virus.
Yes.
Here in the tabular. As you know, I worked with the American Academy of Family Physicians on this a request for revisions to the tabular and the index. So my only question here in the tabular, I'll be back for the index, but my only question here in the tabular is we had asked to have exclude one notes under B97.4 for the combination codes. So for example, could we have an exclude one note for RSV pneumonia, J12.1? And, acute bronchitis due to RSV, J20.5. Was there a reason? What was the reason not to have exclusion notes under
AAP
the
did not
D97.4?
support that.
What's that?
AAP did not support that.
Did they specifically say they didn't support it, or they just didn't comment on it? I wish they were still here, but they left.
I know. No, they did not support it.
They did not support having exclusion notes?
Correct.
Okay. Do we need to come back in September? No, I'm serious.
No, I mean...
Well, yeah.
Please send in your written comments. I wish, I wish they would have stayed, but unfortunately, I know they had a plane to catch, but yes, they did not support that.
I'm not sure if they would feel there could be some potential to have more than one site going on with RSV at once, whether that would have been some of their concern on that. I don't have the
I don't want to
reasoning
draw
on
this
it,
out.
but, yeah.
But, I did have quite an exchange with them, and they kept focusing on that they were fine with just putting the abbreviation, and I kept saying, well, okay, that's great. What about the other points that we made? And we didn't get a chance to look at that yet, or whatever. So it was not clear to me if they were actively opposed to it, or they just didn't comment on it. And I guess that's what I was trying to ferret out. But I will re-engage with them and find out if they are actively opposed to redirecting coders to the combination code, and can take it from there. I did talk to Becky Dolan
Yes.
from AAP, and ask her if I could forward you our correspondence, our email correspondence, and she said I could, so I will do that.
Okay, great, thank you. Darlene?
If you could just scroll up by the T82, the I-21. So this October, we noticed the note says code also, complication if known and applicable. So if the at the beginning, I'm trying to get my thoughts together, sorry.
Okay.
And I might have to cut this short and just put it in writing. But at the beginning of the complication chapter, the T codes, it says, the note at the beginning of complication says to code that first and then use something like code the T code first and then use additional code. But then this note says code also the complication if known. We've been putting the T code first and then the I-21A9 if the MI was due to the stent because of the note in the complication chapter at the beginning. So I just want to point out that note is confusing because it says code also, implying that either can be sequenced first, which is in contrast to the note at the beginning of the complication chapter.
Okay.
Does that make sense? Is that clear?
Yes.
I don't have it in front of me.
So we first proposing it that the T82.1 should go under I-21 with a QMI infraction. Because,
it should be code first.
Right.
Because T would go before
But
the
it's-
I-21.
Right, but should not be specifically under I-21A9, because what happened in the records that when the infraction occurring ready to stand, we know the site, because if we don't know, we ask provider, they'll tell us the actual site infraction. Because they will describe where the infraction takes place, and they will tell relators to know. So from experimental coding couple of chart, I see that. So I'm
Are
just
you
going to...
saying when it's not when it's related,
Well,
then you need to put the T code first. When it's unrelated, then it could go either way. That's
right.
Yeah.
Yeah, but it should not be specific down to that I-21A9 at all, because we do know there's stuff going on with the patient, infraction, very specific where they are, and it relate to TA, we know that. When we query, he would tell us, or cardiologist would tell us that. So I don't think that TA2 should be under the specific that my infraction code.
Okay.
Was it similar or different?
I don't know. I have to think about it. I like that it kind of reminds the coders to code also the in-stent stenosis when the MI, but you might have a good point.
Ladies, please send in your written comments. Okay. Going on. At 036, we're adding inclusion terms there for the various fetal abnormalities, as you can see. And at 099.34, we are correcting the code range there from F01-F09, adding, taking out the and putting F20 to F99, and then adding F F54 to F99. Teresa?
I don't think that makes sense. Do you want F20 to F99, or do you want F54 to F99? Because F54 is included in F20 to F99.
True,
So
okay.
revisit what you're specifically wanting to include. Thank you.
Check numbers. Okay. And at P91.8, we are correcting the code assignment for congenital cirrhosis from P7871 to P7881. And at T28.4, we are deleting the code first note.
That was intended to apply for corrosions, not burns, and if the
Yeah.
codes were following this code, actually.
At V86, we're deleting various inclusion terms that have now their own code at the point, for instance, the V8609 is now, driver of dirt bike injured in traffic accident is now V86.06, and as well as the following, V86.19 is now .16, and so on and so forth. So we wanted to make sure that, that was corrected. At W25, we are correcting the code from, in the excludes one note for subsequent striking against, with fall on same level due to slipping, tripping, and stumbling with subsequent striking against sharp glass from W01.10 to W01.110. And at Z45.018, that's also correcting, revising a range, code range. At Z69.81 and 82, we're deleting the inclusion term at 81 and adding it to 82. And at Z90.41, we're just correcting the alpha order there. And at Z97, we are deleting fitting and adjustment of prosthetic and other devices as exclusion 1 and adding it as exclusion 2. Are there any other questions on the tabular? And I just want to note where we're adding for RSV the various inclusion terms, they will be also indexed in the index. They will be added to the index as well. They're not being shown in the actual index, but they will be added. And in the index, under abscess, gingival, the next items, we're just revising the spelling to make it periodontitis instead of periodontitis. At abuse, we're adding under amphetamine, we're adding the word also, and we're also adding the various subterms. Under anastomosis, we're also adding various subterms. We received a request from a hospital requesting a little bit more definition, a little bit more granularity to the index regarding different aneurysms. So we're trying to make it a little bit better for the coders to look at, in the index. As well as under aneurysm, we're also adding more subterms. Under retina, we're deleting the word C diabetes, micro urisms, retinal. And at atrophy, we're revising the code. Under the main term Braille, we are deleting these two codes as they are not a part of the Braille disease. They are coded elsewhere. And under burn, partial thickness, we are deleting the word unspecified, and actually should be adding second should be underlined, second degree by sight. Under cardiomyopathy, we're adding new subterms for the various sites here, and under seco-uretacil, we're actually adding that to the index, given in the code Q6232. And under Chiari's disease type 2, we're changing the code assignment, and we're leaving the code assignment, but we are changing, we're deleting the word C spina bifida. Under disease, we are correcting the code assignment for Rosbach's hyperchlorhydria from K30 to K31.89. Under findings, we're adding more subterms for under radiologic, for musculoskeletal limbs, and then other than limbs. As well as fistula, we are adding more subterms. Under fracture, we're correcting the under finger index from medial to middle. I think these are the last ones that were left out from the previous index. And we are adding, we are revising the code assignment for Greisenser's disease from B76.9 to B76.0. Under hyperplasia, we're doing addition of some subterms, and we're also revising the we're adding the location, for instance, if it, 1 dash or 2 dashes. So under ductal, we're also revising and deleting atypical, but we're adding another line to that and making it easier, actually put it in the right place. And then under endometrium, we are deleting the word benign and adding a subterm for benign under endometrium. Under infection, we're just correcting the spelling as well for periodontitis. Intoxication with adding more subterms under amphetamines with dependence. Again, under malformation, we're adding more subterms. Under narrowing artery, we are taking the word cerebral and adding pre-cerebral under the various subterms here. Osteomyelitis, we're correcting the code assignment. Again, under perisymatitis, we are changing the spelling for periodontitis. We are revising the, under poisoning, we are revising the code and also taking out the non-essential modifiers. And we are on page 67, and at screening 4, we are deleting invalid codes. They all should direct to Z13.4, as Z13.41 and 42 are invalid. Again, at superoration, I'm probably saying that wrong, but again, correcting the spelling. Under syndrome, we're adding the term Churg-Strauss, as well as revising, taking out the word congestive and adding right. And we are adding the term glass with the code Q87.89, and we are revising the word premenstrual dysphoric from F32.89 to F32.81, and we are also adding SATB associated with the code Q87.89, revising the code at thrombosis vein from I81 to K55.0, and adding more subterms under unstable, not unstable, under varix, we're adding the word with bleeding and ruptured. And under weak, we are revising the code assignment for Zellweger syndrome from Q87.89 to E71.510. And last but not least, under the table of drugs and chemicals, we are revising clozapine from a benzodiazepine classification to an antipsychotic classification. So are there any questions regarding the index? I know I didn't go over everything, but
Just the
Teresa?
Tricyanic IMO, just one thing to point out with the changes that you've made in the index for the ruptured AV brain malformations to add specific codes for the interparenchymal, interventricular. At Q828, where there's an excludes one for excludes ruptured cerebral AV malformation at I60.8, with these new codes that you have added in the index, I think if you probably should be consistent and add those other codes behind ruptured cerebral AV malformation for the other sites, interventricular and so forth. That's my only thing.
okay. Yeah, please make sure you put that in writing. Linda?
Thank you. I know you said that you'll be adding the abbreviation RSV to the index, which I do
Yes.
appreciate. There were several other requests that AAFP made with regard to index changes, and they don't appear anywhere. So I guess what I'm asking is, was there an objection to indexing respiratory syncytial virus under the word virus, which is where people, I think, would look for it?
No, I don't think so.
So should we suggest it again, or I mean, that was part of AAFP's request, was to make some index changes to make it easier for people to find RSV in the index. And a lot of people said, you know, we look under the word virus and there's nothing there. So, and there were a couple other small requests with the, well, I don't know if they were small or not, but there were a couple other requests for indexing changes too. We wanted to try to streamline things by consolidating all the entries for RSV under either the term infection virus or virus, because that seemed to be where most people would look, and where people have been telling us they did look and they couldn't find it. So, you know, a request or two like that. Was that part of the consideration, or no?
No, AAP did not agree to that, or shall I say support that.
Okay, and again, it's not clear if they actively disagreed with it or if they just didn't comment on it. I don't mean to put you on the spot.
No, I mean, basically, I did contact Becky prior to the meeting last week, and what I was told was they agreed to adding inclusion terms to the tabular and the abbreviations into the index were the only things that they agreed to, or supported, I'm sorry, not agreed.
I did follow up with them to ask about the other components there, and didn't really get a specific response on that. So I guess, again, we'll interact with them. But as necessary, we may need to come back and say, put it under virus. That's where people are looking for it. So thank you.
Okay, thank you. Any other questions? Operator, could you open the phone lines and see if there's any questions?
All lines have been opened.
Okay, thank you. No questions. We will end the meeting then. Donna?
Okay, everyone, we have reached the end. I want to thank all of you for staying until the end, and we look forward to receiving your comments. Sooner is always better than later, so while it's still fresh in your mind of all the things that you thought about and maybe didn't have an opportunity to go to the microphone for, please get that to us. And again, even though you may have made comments here, for those on the phone and here in the audience, please, we want those comments in writing. And we look forward to receiving those comments and proposals for possibly the September meeting. And with that, I will close the meeting and wish you all a good evening and safe travels.